Hi, everybody. Good evening. I am Dr. Raina. I think a lot of you know me. So we'll directly start with the class. Okay, so for those of you who don't know me, I am Dr. Raina Chawla. I am a faculty of Obs and Gynae at Cerebellum Academy. And I am also working in Faridabad as the unit head at Sarvodaya Hospital. So those of you who don't follow me can find me on OBG classes by Dr. Raina on YouTube and on Instagram. Okay, so let us start the session. So what we are going to do today is we're going to discuss previous year questions, Neet PG. The focus would be on Neet PG because that's the upcoming exam. So what I've done is I've gathered together the last 3-year questions of obstetrics and of gynecology. And also I've put in relevant other topics which may not have come, but which are potential question areas. And also a lot of new expected things, which are the very in things. So those may also be quizzed. So I've just put together a lot of things for you. I'm going to make it very brief. The topics will be very brief, but the session may go on for a long time. In between, I'll keep reading your doubts. If anybody has any questions, we will, I'll try to see. So somebody's asking, does it include INI-CT questions also? Yes, I've put the important ones through of INI-CT also, but the focus, remember, is Neet PG for this session. Okay, INI will have a separate session, but it does have some questions. Okay, starting. So let's start without wasting time. Okay, so the first question is, and this is first obstetrics, then we'll move on to gynae. So the question is, a 25-year-old primigravida is, just a second. Yeah, a 25-year-old primigravida is on indomethacin 25 milligram 3 times a day for polyhydramnios till 35 weeks. What abnormality can the fetus have if she goes into labor now? Okay, now why do you think indomethacin would have been given? Okay, so indomethacin, remember, is given mainly for 2 reasons in obstetrics. One is it is a tocolytic. Okay, what does tocolytic mean? It is a uterine relaxant. Another reason why it is given is for polyhydramnios because it reduces the amount of liquor. But very importantly, indomethacin is not given after 32 weeks of gestation. Why is that? That is then the answer, because it causes premature closure of the ductus arteriosus. Okay, it causes premature closure of the ductus arteriosus. So remember, if you're giving indomethacin in pregnancy, it has to be given before 32 weeks. Okay, also remember, it is neither the drug of choice for tocolysis, neither for polyhydramnios. What is the drug of choice for tocolysis in pregnancy? The drug of choice is a calcium channel blocker, and usually we give nifedipine. Okay, so remember, if you give it after 32 weeks, it can lead to potentially pulmonary hypertension and fetal death. So that's very important about indomethacin. Okay, now since we're dealing with fetal circulation, the next question also. So fetal circulation is an important topic. Okay, and it is a high yield area. Okay, so the question is, and it's an easy question, deox blood is returned to the placenta from the fetus through what? Okay, now this is also a relatively simple question. Okay, but remember, it's just the opposite. So deox blood is returned to the placenta from the fetus. Is it through the umbilical artery or the umbilical vein? Remember, deox blood comes back to the umbilical artery. Okay, so you have the placenta. Okay, and the placenta gives oxygenated blood, and this travels through the umbilical vein. Okay, but remember, the umbilical artery is what carries the deox blood back to the placenta. Okay, now this is a little important, and we will discuss a bit of the fetal circulation here. So you have the placenta carrying oxygenated blood through the umbilical vein. Now the umbilical vein will divide into the porta hepatis, okay, and the ductus venosus. Okay, and this ductus venosus will carry the oxygenated blood to the right side of the heart. Okay, and from here it will go partly to the left side of the heart or through the left to the right ventricle, and through the ductus arteriosus. Okay, the oxygenated blood will go to the remaining fetal body. Okay, and then through the hypogastric arteries, which form the umbilical arteries, the deox blood is returned back to the placenta. So just remember, it is opposite. Okay, so the umbilical vein carries oxygenated blood and the umbilical artery carries deoxygenated blood. Okay. Next question. A married woman gives birth to twins. The husband doubts he's the father and gets a paternity test done. The test shows that he's the father of one infant but not the other. What is this called as? Anyone? This is a case of, is it superfetation or superfecundation? That is the main doubt, right? So this is what most of you get confused with. This is superfecundation. Remember, superfecundation is what is seen in humans. Okay, and superfetation is not known to happen in humans. Now, this is a classical picture from Williams. And what basically superfecundation is that what happens is in the same menstrual cycle, 2 ova are released. Okay, and through different acts of sexual intercourse, the 2 different fertilizations happen, leading to 2 different, genetically different twins. Okay, so in the same menstrual cycle, if fertilization of 2 ova happens, it is called as superfecundation. Superfetation has not known to occur. Okay, so this is the classical picture given Williams. Again, a relatively simple question. Okay. So next question, a 28-year-old primigravida who is a known case of mitral valve replacement presents at 36 weeks to the antenatal OPD. She's on warfarin 4 milligram, which is correct regarding anticoagulant therapy. Okay, so what will you do? She's a known case of mitral valve replacement and she's on warfarin 4 milligram. Okay, should we start heparin? Should we start heparin and aspirin? Okay, should we start only aspirin or should we continue the warfarin? Okay, now the answer to this question is to discontinue warfarin and start heparin. Okay, so remember, a woman who is on anticoagulant therapy, so women who have heart valve replacement done, they usually are on warfarin. But remember, warfarin is teratogenic. Okay, and it also can increase the risk of intracranial hemorrhage in the fetus. That's why the first trimester and the third trimester are times when it should not be given. Okay, so in the first trimester, it increases the risk of something called as warfarin embryopathy. Okay, and remember, this happens when the dose is more than 5 milligram per day warfarin if she's getting. Okay, less than 5 milligram, the risk of warfarin embryopathy is very, very less. Okay, in the third trimester, again, we need to change over the drug. So any woman who comes to us and she's pregnant and she's on warfarin, the first thing we need to do is we need to change warfarin to unfractionated heparin in the first trimester itself. This will reduce the risk of warfarin embryopathy. Okay, especially if she's taking more than 5 milligram per day. What do you do then? In the second trimester, she can be reconverted back to warfarin because warfarin is actually a better anticoagulant than heparin. Okay, especially for women with artificial valves. Okay, but in the third trimester, it's very, very essential to shift her back to unfractionated heparin. And this is usually done between 34 to 36 weeks. Okay, and after she's delivered, also remember, before delivery, 6 to 12 hours before delivery, we again stop the warfarin, the heparin, and restart it 12 to 24 hours after delivery. Okay. Once she's delivered, 12 to 24 hours later, we start both heparin and we add on warfarin and gradually stop the heparin. Okay, so postpartum, remember, in the postpartum period, warfarin is safe. Okay, a question can come because this is one topic which is usually asked. Warfarin is safe in breastfeeding mothers. It is only not to be given in the first trimester, especially if she's taking more than 5 milligram per day, and in the third trimester because it increases the risk of intracranial hemorrhage. Okay. Okay, so the next question. Okay, so this is again a very easy question, and I don't think anybody should get these kind of questions wrong. Okay, but we'll quickly go through this because this has come almost in every alternate paper. If you see, you get this question, okay, or something related. That is the parity index. So a 25-year-old woman presents to the antenatal OPD. This is her second pregnancy, and her first pregnancy was 4 years earlier, where she delivered twins at term. What is her parity index? Okay, so what is the answer to this? This is a very easy question. This is her second pregnancy, so she is gravida 2. Okay, yes, the answer is A. And para 1. Okay, now why is it gravida 2, para 1? Why is it not G2, P2? Let me explain a bit further. Okay, so when we write a parity index, we have G, we have P, we have L, and we have A. These are the main ones, right? What is G? G stands for gravida. What does gravida mean? Gravida means the total number of pregnancies, okay, including the present pregnancy. That's very important. Including the present pregnancy, irrespective of the period of gestation. Okay, so she's pregnant now means she's gravida. Okay, so whenever we say gravida, it refers to a pregnant woman. Okay, so total number of pregnancies, including the present pregnancy, is gravida. What is para? Para is the total number of pregnancies that have crossed the period of viability, but excluding the present pregnancy. What does this mean? The total number of pregnancies more than the period of viability, and this is sort of a gray area कि हम कितने weeks पे हम इसको period of viability मानेंगे. What do you mean by period of viability? That means at the gestational age beyond which the baby can survive, okay, without much help. Okay, so usually this is taken as 28 weeks in our country, and the WHO also takes it at 28 weeks. But the Western world will take it around as 24 weeks because they have much better neonatal intensive care services. Okay, so we take it as 28 weeks. मतलब इसके बाद बच्चा most likely survive कर जाएगा. ठीक है, even if we have a preterm delivery. So para is the total number of pregnancies. Okay, excluding the present pregnancy. अभी वाले pregnancy को include नहीं करना है. ठीक है, after the period of viability. Please make this very clear inside your mind, because a lot of people go wrong here. What also was asked here is twins. Okay, so remember, twins is the number of fetuses. What is parity? Parity is the number of pregnancies. Pregnancy is 1. Babies may be 2 or 3, triplets or quadruplets, doesn't matter. That will come in your living. Okay, if they were live births. Okay, but para is pregnancy. Pregnancy एक था, twins थे, but pregnancy is 1. Okay, so gravida, para. L is live, how many live issues she has. And abortion. Now, abortion by definition of WHO is any fetal loss before 20 weeks or less than 500 grams. This again leaves a gray area between 20 weeks and 28 weeks. कि इसको क्या कहेंगे, है ना? So this is a gray area. It is recognized as a gray area. So don't worry about this. If it comes in the exam, it will be very clearly given. Okay, because this is a known gray area. All guidelines, all associations have said that we don't know what to call this. Okay, so gravida and para should be very, very clear in your mind. Okay, next question. A 28-year-old primary is in labor. She has repeated urge to pass urine and has premature bearing down. On examination, there is infra-umbilical flattening. Okay, so she has lots of clues. So when you get clinical questions, remember, na, बहुत कम questions है जिसमें there'll be just one clue. Most of the questions will give you a lot of clues to tell you कि this is what we're asking. So what is the first clue? She has repeated urge to pass urine. Second clue, she has premature bearing down. Third clue, there is infra-umbilical flattening. Fourth clue, the fetal heart is on the lateral side. What is the most likely presentation? All these four are characteristic features of occipito-posterior. Okay, so let me just see some questions have come in. If previous one is stillbirth, then yes, it still remains the same. Para still remains the same, irrespective of the outcome. Okay, any pregnancy which has crossed the period of viability, irrespective of the outcome, but excluding the present pregnancy, becomes a para. Whether she had a stillbirth, intrauterine death, doesn't matter. Okay, it is a para. Okay, so this is B, occipito-posterior. Everyone's got this right. Okay, what is occipito-posterior? So this is occipito-posterior. Can you see? The occiput is here. It is posterior. Now, because it is posterior, can you see this? This is called as infraumbilical flattening. It won't be a smooth, round structure like normally when we examine gravid uteruses. It will be nicely smooth. When you see this just on inspection, okay, this is the biggest clue that this is occipito-posterior. Okay, these are the points. They will have early rupture of membranes, premature rupture of membranes, frequent feeling of passing urine, premature bearing down. Okay, and the head is commonly unengaged because it is commonly deflex. So jahan pe bhi deflection hai, that's another clue. Deflection is always associated with occipito-posterior. Okay, and fetal heart is heard right either on the extreme flanks, but it can also be heard right at the center. Okay, now a few more important points you should know is kaun se type of pelvis mein common hota hai. Where do you find occipito-posterior? Which type of pelvis? Anyone? Which is the commonest pelvis associated with occipito-posterior? It is an anthropoid pelvis. Okay. Anthropoid pelvis is the most common pelvis associated with an occipito-posterior. Android pelvis also, yes. Okay, but it is second most common. So remember this. If your question comes, so many of you answered android. Remember, anthropoid classically with occipito-posterior, android classically with obstructed labor. Okay, android classically with obstructed labor. Anthropoid is the more common with occipito-posterior. Okay, and when we talk about platypeloid का common association क्या है? Platypeloid with delayed engagement or something called as asynclitism. Okay, so these are the common associations. Okay, anthropoid, most common occipito-posterior, android, obstructed labor. Platypeloid is when the engagement itself doesn't happen or is delayed, and it is associated with asynclitism. Okay, next question. Following delivery, a woman has atonic PPH. Okay, despite conservative measures, the bleeding persists. Okay, can you just hold on for a second? I am getting a call from the labor room and I have to take this. Just a second. So that's the problem with being a gynecologist. Somebody was persistently calling me from the labor room, so I had to take it. Apologies. Okay. So following delivery, a woman has atonic PPH. Despite conservative measures, the bleeding persists. Okay. She's been taken to the OT where the surgeon proceeds to do a devascularization. Now, first of all, remember obstetric emergencies. Agar aap ye wala Neet PG de rahe ho, तो emergencies जो है obstetric emergencies, and I've listed them out down in the end also. Okay, always a question will come. Okay, that means APH, PPH, shoulder dystocia, cord prolapse, eclampsia, amniotic fluid embolism. Okay, placenta accreta. Okay, these are our nightmares. As an obstetrician, if this happens in my labor room, it is literally a nightmare. Head bahar aa gaya, shoulder stuck ho gaya, cord bahar aa gaya. Okay, and very unexpectedly these happen. That's why in your exam they ask these questions, because you need to know how to give at least basic management or what needs to be done immediately. So obstetric emergencies, definitely one question comes, not even one, maybe 2 or 3 come. Okay, so that is one area which you should not miss out. I have listed them in the end. So if you see in this last 2 or 3 years also, so many questions come on obstetric emergencies. It is a question and it is a very commonly asked area because it is very important to know. Okay, so they are asking in this question, which are the arteries you will ligate in a devascularization procedure. Okay, and yes, all of you have answered A. A is uterine, ovarian, and internal iliac. So ovarian exactly nahi hai. It is basically the anastomosis or the uterine branch of the ovarian artery. Okay, so if this is the uterus, okay, so the first thing we do in these three, what is the first thing we do? If the patient is bleeding on table, what is the first artery I will want to ligate? I will want to ligate the uterine artery. That's the first one I will want to ligate. The second one, what will I do? I will ligate the ovarian uterine branch of the ovarian. Okay, somewhere here at the cornua. And the third artery I ligate is the internal iliac artery. Okay, that is the anterior division of the internal iliac artery. Okay, so the question can come in a different way. The order can be asked, and this is the exact order: the uterine, then the uterovarian branch, and then the anterior branch of the internal iliac artery. Okay, so that is important. Okay, now in PPH, since we are discussing PPH, let's go into a bit more detail because it is required. Okay, what is AMTSL? AMTSL is active management of third stage of labor. ठीक है, अब इसके components क्या है? And remember, इसके components change नहीं हुए. Many of you get confused कि पहले कुछ था फिर कुछ और हुआ. They have not changed. The components are the same. They haven't changed. Okay, let me clarify a bit more. Okay, in 2009 this came about. The WHO gave the term AMTSL, and AMTSL is basically prevention of PPH. Okay, the basic aim is to prevent atonic PPH. Which PPH? Atonic PPH. So basic three components kya hai? What are the basic three components? The first is, what is the first one? The first one is use of a uterotonic. Okay. The second one is controlled cord traction. And the third one is uterine मसाज. ओके, ये 3 बेसिक कंपोनेंट्स है, ये चेंज हुआ. इनफैक्ट गवर्नमेंट ऑफ इंडिया ने इससे पहले एक और ऐड किया कि फर्स्ट एब्डोमिनल एग्जामिनेशन करके चेक करो कि सेकंड बेबी तो नहीं है. Check, do an abdominal palpation and see if a second baby is not there, because you should not give a uterotonic if it is twins. Okay, and this is in the Government of India manual as part of AMTSL. It came in your last INICT also. This choice was there. Okay, first exclude another baby, because if you give your uterotonic without excluding, the uterus will close over the second baby. In the primary healthcare centers, many places, and I have delivered many patients who didn't know, we didn't know that they're twin. Even our examination failed to determine ki twin pregnancy tha, and after the first baby comes out, you realize there's a second baby inside. So always, once first baby is out, re-examine the patient. Exclude second baby is actually the first point. But the WHO says these 3 points. Okay, uterotonic, controlled cord traction, and uterine massage. Okay, so what happened in 2012? The WHO came out with another document. Okay, what was the other document? What are the main points? They said, number 1, uterotonic may prefer oxytocin. Okay, this is what they said. And what did they say? Which either IV or IM is to be preferred. This is what they said. Okay. Secondly, what they said is they said CCT tab karo if a skilled birth attendant is there. Otherwise, don't do it. So only in the presence of a skilled birth attendant should you do the controlled cord traction. Otherwise, what was happening? A lot of uterine inversions were happening. Okay. Third, what did they say? They said you do a uterine massage only if the uterus is atonic. So they just changed the wordings a bit. They said uterine massage, do it. Do basically the term they used was postpartum vigilance. Every 15 minutes, palpate the uterus. If it is not contracted, do a massage. Okay. And the fourth thing they added here was what? They added delayed cord clamping. Okay. And those of you who've seen my Insta video today would know that delayed cord clamping is done, should be done. Okay. In most mothers, okay, except certain situations which we will tell. Okay, but delayed cord clamping has to be done. It is mandatory. That means 60 seconds we have to allow blood to flow to the fetus to reduce fetal anemia, and then clamp the cord. So this, remember, point number 4 will not reduce postpartum hemorrhage. But WHO used this AMTSL theme as a message कि इसको भी include करो, include this also. It's not going to prevent PPH. Remember this, delaying the cord clamping is in no way going to prevent PPH, but sort of as a emphasis, especially in the primary healthcare centers, कि ये भी करना है तो include क्या है. Okay, I hope I'm clear. And then in 2018, another document came out where it specified कि आप oxytocin के अलावा you can use other drugs also. You can use carbetocin, you can use misoprostol, you can use methergin, and you can use symptometrin, which is a combination of methergin and oxytocin. Okay, so 5 drugs can be used. So this is what AMTSL is. Very, very important topic. That's why I have spent some time on this. 3 basic वाले तो है, ये change नहीं हुए, ना कभी change होंगे. They will never change. Remember this. They are always there. what has been added is delayed cord clamping. Okay. And what oxytocin is the main drug, is the drug of choice if it is asked for prevention of atonic PPH. Okay. I hope this is clear. Okay, somebody's asking my Insta ID is OBG classes by Dr. Raina, but an underscore in between the words. Okay, right. Okay, yeah, everybody's answered correctly. Okay, now also in PPH, you should know the first step is mechanical and medical methods before moving on to devascularization. Okay, so mechanical and medical methods need to be tried, the same uterine drugs which I've told you. Okay, so mechanical and medical method go hand in hand, and then come surgical methods. In surgical methods, we've already discussed devascularization. What are compression sutures? You may get an image like this. What is this image of? These are brace sutures, also called as, by the person who identified them. Okay. These are also called as B-Lynch sutures. These are the most common type of brace sutures we use. So what they are doing is they are compressing the uterus. Okay. And so first, what do? We put our hands and we compress the uterus. If the bleeding stops, then only we know this will work. Then only we put the compression sutures. Otherwise, we straight away move to a hysterectomy. So iska koi order nahi hai. Okay, there is no order. In the devascularization, yes, you can try these three. But otherwise, it depends on the situation. If the patient is in complete shock, you may directly decide to do a hysterectomy. Okay, but these are the different surgical methods we have available. And there is one more method, uterine artery embolization. This is preferred for those women who are hemodynamically stable. Okay, and it is usually more often used in secondary PPH. This is in obstetrics, not in gynae. In gynae, where do we use uterine artery embolization? What is the main indication in gynae? In obstetrics it is PPH, but that too in a stable patient. Also in placenta accreta syndromes. Okay. In UAE, yes, UAE, where do we use UAE? Anyone? The main indication in gynae, I'm asking, is fibroid uterus, especially in those women who don't want to conceive, who don't want conception. Okay, and it's very commonly being used for fibroids. Okay. Next question. A 21-year-old primigravida presents to the antenatal OPD. Her school-going nephew who lives in the same house has contracted varicella. Okay, what is varicella? It is chicken pox. Okay, a blood sample is taken for antibodies against varicella. The report is negative. What does this signify? What does this mean? Okay, and how do we manage such patients? Because this also has started being commonly asked: varicella, herpes, rubella, syphilis in pregnancy. So infectious disease in pregnancy is becoming a very commonly asked topic, COVID in pregnancy. This means that, yes, she is susceptible to chickenpox because the IgG is negative. Okay, so she is susceptible to developing chickenpox. Now, what should we know about chickenpox in pregnancy? There are two kinds of scenarios we have. One is a woman who is exposed. Okay, so your clinical question can come like this. Here, 24-year-old primigravida who is a school teacher, okay, is exposed to a student in her class who has chickenpox. Okay, that is the most common scenario they ask. Okay, so, or she's exposed to her younger child or her nephew in the family who has chickenpox, and she's very worried and she comes to you. Okay, so history of exposure. Dusra case aa sakta hai कि patient comes with chickenpox. Now what do you do? So the rash has developed. Okay, so in the first scenario, what should you do? If she has exposure to chickenpox, you should first ask her immunization status. Okay, if her immunization status is known, very good. If she says कि I've been immunized or I've had chickenpox in my childhood, then nothing to worry. Okay, but if she doesn't know her immunization status or she's uncertain, okay, then we sample her. We get a blood test to determine the immunity to varicella zoster. That means we do an IgG. Okay, if not immune, if it comes IgG negative, we give her VZ, varicella zoster immunoglobulin, within 10 days of the exposure, the history of exposure. Okay, so that's very important. We give the varicella zoster immunoglobulin. We don't give the vaccine. We give varicella zoster immunoglobulin if she's exposed and if she's IgG varicella negative. That's the first point. The second point is if she comes with a rash. Okay, there's a lot of stuff written here, but I will tell you in very simple terms. If she comes with a rash, remember, now she's exposed. Okay, so what are we worried about? We're worried about number one, congenital varicella syndrome. The maximum risk is between 13 to 20 weeks. So if the exposure is at this time, you need to be worried. The baby may develop congenital varicella syndrome. Okay, so she should be referred to a fetal medicine specialist, okay, who will try to determine, maybe an amniocentesis is required or an ultrasound is to see if the features of varicella syndrome are there or not. Okay, the second time you're worried about is if she delivers it near term. Okay, near term, we don't want her to deliver. Remember, if the question comes and it has come previously 38 weeks with chicken pox, what should you do? The answer, one of the options will be expedite delivery. No, we have to not expedite delivery. We have to wait until the rash has crusted over. Why? Because neonatal varicella has very high mortality. If you deliver expedite delivery, mother के antibodies नहीं बने, fetus को नहीं जाएंगे, baby will have neonatal varicella, which has up to 50% mortality rate. Okay, so near term, avoid delivery. Okay, and all, give the woman acyclovir. Whenever she comes to you, acyclovir has to be given. So two important points. Early onset is bad. Second trimester, 13 to 20 weeks, highest risk of exposure. This has come as a question previously. This has come as a question previously. If she develops varicella at term, avoid delivery. Try to avoid delivery. If she is come in labor, you can't help it. But if she has come not in labor, avoid delivery. Remember, also, there is no point of giving immunoglobulin once the rash has set in. So immunoglobulin has no role. It's only for prophylaxis, for exposure, no role once the rash has set in. That's another important point. Okay, are we clear on varicella? Let's move on. Okay, so as I said, congenital varicella syndrome, there is chorioretinitis, microphthalmia. These are very common to most of the infections. Okay, and this is what you need to remember. 13 to 20 weeks, highest risk of fetal infection, that is congenital varicella syndrome. Okay, next is another infection. Okay, so I put the infections together. You can see, so one area which commonly you get questions is infectious diseases in pregnancy. Okay, somehow they like asking this, although we don't see it commonly in practice, but they like asking this. A 28-year-old primary gravida presents at 36 weeks with painful vulval ulcers. Okay, so when you see painful vulval ulcers, think of genital herpes. Okay, this basically means this. Okay, painful vulval ulcers is genital herpes. Okay, for all practical purposes. Okay, and she does not give history of similar lesions in the past, means this is primary genital herpes. Okay, on examination, there are multiple painful vesicular lesions, which is the best treatment option. Okay, the best treatment option, okay, in a patient who is term, remember, in a term, how will we deliver this patient? We will do a elective LSCS. Remember, this is one of those infections which is a direct indication for a cesarean section. Why? Because the ulcers have a lot of viral shedding in them. Jaisi fetus uske contact mein aayega during a normal delivery, what will happen? Neonatal herpes will happen. That has a 80% mortality rate, very high mortality. We don't want the baby coming anywhere near the mother's lesions. Okay, so elective LSCS is the treatment of choice. Here it is asked at 36 weeks, but still the preferred answer would be this. Okay, because we have to give acyclovir, that is the drug of choice, and we have to deliver her. 37 hota to better answer hota, obviously, but 36 where nothing else fits in this. Okay, and so this would be the best answer for this. Okay, we don't give antibiotics, we give acyclovir, and we do an elective LSCS. We don't induce, we don't allow a vaginal delivery, especially for primary genital herpes. Okay. Okay, so herpes simplex, painful vesicular lesions. very high risk of neonatal infection, up to 80% mortality happens with this. Okay, so elective LSCS for active primary genital HSV infection. Okay, rubella in pregnancy, what are we worried about? Congenital rubella syndrome. Okay, I think most of you know about this. We'll quickly skip this. About rubella, one more thing, very important. Sorry, very, very important. Rubella vaccination. Should we give in pregnancy or not? So somebody's asking if 32 weeks. Yes, if 32 weeks, you will wait. Herpes, you will wait. Only if you're planning delivery, you will deliver by a cesarean section. Okay. Yes, congenital rubella syndrome is right. Rubella vaccination, dena chahiye, nahi dena chahiye. Should we give it or should we not give? Rubella vaccination is contraindicated in pregnancy. Okay. It is usually given as part of, because again of the concern of congenital rubella syndrome, it is usually given as preconceptionally to mothers, okay, with the advice that they should not conceive for at least 1 month. Okay, that is the advice given. They should not conceive for at least 1 month, preferably for 3 months. Okay, avoid conception. Okay, and if they are unimmunized, we can also give them a shot postnatally. In fact, this is the better time to give them the shot once they have delivered. Okay. Syphilis, what should we know about syphilis in pregnancy? Although it's very rare, but still they love asking something called Kasowitz law. What is Kasowitz law? Okay, somebody's asking if given in first trimester, is it an indication for MTP? No, it is not an indication for MTP, but the risks of congenital rubella syndrome have to be explained to the woman, but it is not a direct indication for MTP. Okay. Such controversial questions, recipe they will not ask. Okay. All live vaccines avoided in pregnancy, except which vaccine? Somebody's asked. All the live vaccines are avoided in pregnancy, except which vaccine? So all live vaccines are avoided except yellow fever vaccine. And this is given only if the woman is traveling to an endemic area. It can be given. Okay. Otherwise, all live vaccines are contraindicated. Okay. What is Kasowitz law? It is syphilis in pregnancy. Okay. Congenital syphilis. Basically, it refers to congenital syphilis. What happens is, with every pregnancy, the outcome of a woman who has syphilis, the pregnancy outcome improves. So improving outcome with each pregnancy. So isme classical history kya hoga? Classical history will be that initially she had a miscarriage or abortion, then she had a stillbirth at 30 weeks, then she had a stillbirth, and then she has now a live baby. So improving outcome with each pregnancy. Which characteristic complication in pregnancy has worsening outcome? So these when we teach, we usually say this: improving outcome, syphilis; worsening outcome is RH isoimmunization. With RH isoimmunization, outcome keeps worsening because more and more antibodies keep building up in the mother against the fetal red blood cells. So worsening outcome. Improving outcome with syphilis, worsening outcome with RH. Okay. Okay, herpes we've discussed, varicella we've discussed. Parvovirus. Parvovirus, what is important to know? The baby can have fetal anemia. Okay, leading to high drops. Rabies can be given in pregnancy. Remember, somebody's asked rabies. Okay, rabies can be given in pregnancy safely. Okay. Okay. COVID, what should we know about COVID in pregnancy? Anything specific, anything special about COVID? Remember a few things. Remember that outcome or severity is worse in pregnancy. Okay, severity is worse in pregnancy. Okay. What else should we remember? Should we do cesarean in COVID? Is it an indication for cesarean section? No. So cesarean is done only for obstetric indication. Okay, it is not done because she is COVID-19 positive. Is there vertical transmission? Does the baby get the vaccine, get the virus? Vertical transmission Initially, it was said no, but now a few rare reports have been reported. Okay. And fourth, any precaution in labor? Should we do an early cord clamping? No. So no major precaution in labor. Okay, don't get confused. Delayed cord clamping can be done. Okay, the only precaution to take is mother should wear a mask. Okay, masking and hand hygiene, especially during breastfeeding. Okay, so these are the main things about COVID-19 in pregnancy. Now more and more evidence has come out. So nothing major. These are the main things you should know. Okay, next question. Okay, this is some year. A woman is a chronic hypertensive. She visits the clinic for preconceptional counseling. So which antihypertensive drug needs to be stopped? Okay, very easy question, but repeatedly asked in the exam. Which drug should we stop? We should stop. Yes, we should stop AC inhibitors. Also, angiotensin receptor blockers are contraindicated. Why are they contraindicated in pregnancy? Because they lead to fetal renal agenesis. When they lead to fetal renal agenesis, what will this present as? It will present as oligohydramnios because there is no liquor being produced. Kidneys have not developed in the fetus. Liquor is not being produced. Oligohydramnios, which is early onset. Okay, and this leads to something called as Potter's sequence or Potter's facies, which you have a typical flat-faced appearance along with pulmonary hypoplasia because the lungs don't have space to develop because of absent liquor. Now, important teratogenic drugs. Okay, let's discuss this. Okay, this always comes. Remember, one question out of this will come in your exam. Okay, so we've discussed fetal renal hypoperfusion, AC inhibitors, and ARBs. Let's go through the other important ones. Anti-epileptic drugs, what will they cause? They cause something called as fetal hydantoin syndrome. Okay. Which is this? Which drugs, which anti-epileptic drugs in particular? Phenytoin. Okay. And sodium valproate also is known to cause one of the worst drugs to be given in pregnancy, sodium valproate. Phenytoin typically causes the fetal hydantoin syndrome. Alcohol causes fetal alcohol syndrome. Lithium, I think we all know Epstein's anomaly. Okay. Indomethacin we've discussed. Premature closure of the ductus arteriosus. Methimazole given for hyperthyroidism. Cutis aplasia, which is a skin lesion. Warfarin, we've discussed warfarin embryopathy in more than 4-5 milligram per day dose. Thalidomide is no longer given, but very commonly that baby comes with short limbs, phocomelia. Okay, so I think all of you have that image in your mind. Methotrexate causes clover leaf skull, and diethylstilbestrol, again, very common. These drugs are not used anymore. Okay, thalidomide used to be given as an antiemetic in the 1960s. Okay, and it's still being asked today, because these are classical examples of teratogens. That's one reason why they love asking. These are classical examples. Probably you won't see such classical examples anymore because so many studies are done before they are brought out in the market. Okay. And diethylstilbestrol is was used for recurrent miscarriages, recurrent abortions, again in the 1960s. And women who gave birth to babies are actually called DES daughters and DES sons, and they are now in their 50s and 60s and 70s. So their generation is also on the way out. Okay, so hopefully we won't see these, but DES has been known to be associated with clear cell adenocarcinoma, T-shaped uterus, and in male fetuses or male neonates, hypospadias, and all have come as a question. This has come, this has come, this has come. All of these have come as questions in the last 5 years. This is how important this table is. These are some places where you can't go wrong. Okay, so these are the questions which are very important. Okay, next question. Okay, this is also very important. Expect one question from this. Okay, let's see what this is. A 28-year-old woman with a history of infertility for 3 years presents with 6 weeks amenorrhea. Okay, so she is 6 weeks amenorrhea. She has pain and spotting. Her UPT is positive, weekly positive. Okay, on examination, she is stable. That's a good thing. Okay, she has left-sided adnexal lesion, and ultrasound reveals a left side. So the diagnosis is given. She has a left tubal ectopic, which is unruptured, okay, because she's stable and the sac is seen and there is no cardiac activity. So what is the best management option? Now, ectopic pregnancy, remember, is a must know. Okay. Again, it is in the list of obstetric emergencies. Okay. That's why it's important. Also, lovely clinical questions can be made from this topic. Okay. You can play around and make different situations, different scenarios. So that's why, again, it's commonly asked. Okay. So early pregnancy bleeding is a topic you should be comfortable with. You should be able to answer clinical questions. Okay. So mixed responses we're getting here. What should you do? Okay, let's discuss more about this. Then I'll tell you the correct answer. Okay. Now, when it comes to ectopic pregnancy, okay, how do we diagnose ectopic pregnancy? A patient comes to us. What is the classical triad of symptoms? The classical triad of symptoms are amenorrhea, bleeding, and pain. Okay, so she'll have amenorrhea, bleeding, and pain. You examine her, you investigate her, and you come to a diagnosis of either an unruptured or a ruptured ectopic. Ruptured mein kya karoge? Ruptured mein kya karoge? What will you do in ruptured? If the question comes that hemodynamically unstable, pulse is 120, blood pressure, she's in hypo, she's having hypotension, severe abdominal pain, you will directly do a surgery. Okay, you will take her up for laparotomy or a laparoscopy if she's stable. Okay, but the rule is unstable patient, laparotomy. Okay, so you will directly take her for surgery. Remember, if she is ruptured, don't waste time. You will not even waste time for an ultrasound. You will not waste time for a beta HCG. We don't have time. These patients are bleeding to death. Okay. They are nightmares. As I said, obstetric emergencies. So rupture, agar lag raha hai clinical question mein, if the clues are there, that she is unstable, she's having guarding, she's having rigidity, she's having tachycardia, she's having hypotension. I'm telling you this again, it may seem very obvious. But when you see the options, you start thinking, okay, one thing which I keep telling my students is, in the exam, before seeing the options, try not to look at them, because once you start looking at them, you start getting confused. Okay. Try to form the answer before you look at the options. That would be the correct answer. Okay. Once you start looking at the options, you start getting confused. Okay. So ruptured would be directly, you would do a surgery. No doubts about this. What surgery? You will do a salpingectomy. Ruptured ectopic, the tube has gone. You can't. The question will be given, she had a ruptured ectopic earlier. She's very anxious to conceive. Now again, she's come with rupture. They will try to intimidate you into looking for a conservative option. But once rupture is there, you can't do anything. You have to remove the tube. Removing the tube is called a salpingectomy, where we remove the entire fallopian tube. Unruptured, when it comes to unruptured, here is when we have all our options. Okay, we can either do expectant. What is expectant? Expectant is kuch nahi karna. We just have to wait and follow her up with beta HCG values. Okay, because another question, what is the most common outcome of a ectopic pregnancy? Is resolution. वो अपने आप ठीक हो जाता है. In 80% of cases, ectopic will resolve by itself. It's only in a few cases where it will either rupture or result in a tubal abortion where she will have symptoms. Majority, nothing will happen. That's why expectant management is one situation which we can do. That is nothing but monitoring. Next is medical management. Medical management means giving methotrexate. Okay. How do we give this? 50 milligram per meter square. Usually a single dose. It can be repeated if required. Okay. This is what is medical management. And surgical management is doing a surgery and either doing a laparoscopy, okay, or doing a laparotomy. Laparotomy is preferred if she is unstable. That means in a ruptured ectopic. Laparoscopy you can do in a stable unruptured. It is the preferred surgery in a stable unruptured patient. Okay, and we can conserve the tube if she wants to conceive further. And if the ectopic is small, we can conserve the tube by doing a salpingostomy. That is just putting an incision over the tubal area and taking out the ectopic. Okay. So this is what is done. Now we have to decide between these three. Hame kaun sa karna? Should we do expectant? Should we do medical? Should we give surgical? And for that, there are guidelines. Okay. So expectant management is, remember, all these four, in fact, have to be fulfilled. No pain. She has no pain. Mild pain with everything else? No, you can't. So no pain, zero symptoms, absolutely fine patient who walks in my OPD with a report, ultrasound report saying that it is an unruptured ectopic. She has no symptoms. Okay, no pain, clinically stable. Beta HCG, if I get done, is less than 1000. And the sac size is less than 3.5 centimeter, 35 millimeter, with no cardiac activity, and she's able to return for follow-up. Okay, अब ये कैसे याद करोगे, है ना? Remember this by this is how I remember it. No pain in giving somebody rupees 1000 and returning it in 35 days, right? 1000 rupees dene mein nothing happens, right? So no pain in giving somebody 1000 rupees and returning it, getting it returned in 35 days. Okay, so no pain, beta HCG less than 1000. Okay, coming back for follow-up, returning. Okay, the person is returning back, and 35 days means less than 3.5 centimeters. Okay. So this is where you will do expectant management. That is, you will do weekly beta HCGs and just keep her on follow, because majority of such cases will resolve. Okay. Now, medical management kab karoge? Medical management is methotrexate. So an unruptured ectopic pregnancy with the patient stable, no significant symptoms. That means she could have mild pain. Okay. No significant, nothing significant, no severe pain. Okay. Then the sac size still less than 3.5 centimeter, no cardiac activity, and beta HCG less than 5000, and no contraindication to methotrexate. That means you should not be having some kidney disease or liver disease or severely anemic. You should be able to no major contraindications for giving methotrexate. So remember, all of them have to be fulfilled. Okay, she should have minimal pain or no symptoms, no significant symptoms, stable patient, sac size less than 35, no cardiac activity, serum beta HCG less than 5000. Okay, and no contraindication to methotrexate is when you will give methotrexate. How much do we give? 50 milligram per meter square intramuscular. Usually a single dose is sufficient. Okay. Yes, somebody saying HCG cutoff is different in different tests. You're right. This is what I'm giving you is Williams. Okay, Williams says 5000. Williams also says, as you, so I have given methotrexate for 7000, 8000 also, but that is a postgraduate question. Okay, what happens as the beta HCG levels increase? Okay, you have to explain to the patient the chance of this working out is less. Okay, we can give you medical management, but the chance that you will end up with unresolved or a rupture is higher. So best is less than 5000. This is Williams. This is also the same is given in the RCOG guidelines. Okay, and in the UK, this is very, very strictly followed. So whatever I'm showing you is book, and our standard book is Williams. If there anything differs, I tell you, and I tell you the reference also. Okay. Now, okay, somebody is asking when to give medical and when to give expectant. Both criteria looks the same. Criteria is not the same. Remember, इसमें क्या difference है? इसमें है कि उसको pain mild हो सकता है. Expectant में no pain. Okay, no pain at all. And major difference is the level of the beta HCG. In expectant 1000, in medical it is 5000. Okay, and in surgical, what is there? Significant pain. So she is having severe pain. Or तो इसमें और आ रहा है. That means any of these you won't wait. You will directly take her for surgery. So significant pain or size more than 35 or fetal heartbeat visible on a scan or serum HCG more than 5000. Okay. So how do we remember this? We remember this as there is a lot of heartache in giving 5000 rupees and not getting it returned in 35 days. Okay. So medical wala is anything in between these two mnemonics. Okay. I hope this makes it a little clear. There's a lot of heartache. That means lot of pain and heartbeat is present. Okay. in giving 5,000. So 5,000 se zyada agar beta HCG hai and not getting it back in 35 days, that means size is more than 3.5 centimeters. Okay, if you find this hard to remember, otherwise try to find, this is one mnemonic I've given you. You can make another mnemonic also for the medical one, but I keep it simple. Expectant के लिए वो, surgical के लिए ये, in between जो भी आता है वो medical management के लिए eligible है, ठीक है? But remember any of these, okay? Or is very important. Pain है या size ज़्यादा है या heartbeat है या beta HCG ज़्यादा है, then we will directly do surgical management. And in surgical management, laparoscopy is the surgery of choice for an unruptured ectopic. Laparoscopy for unruptured. Okay, and we can do again a salpingostomy or we can do a salpingectomy. We remove the tube. Okay, salpingotomy, somebody was asking. So there's a lot of fine line confusion. Okay, remember what we do is we just give an incision and we remove the ectopic, whatever is inside. Okay, if you suture it back, it is called a salpingostomy. Okay, what we do is we do a salpingotomy and or we do a salpingectomy. We don't suture back the incision. We just give an incision and we take out the ectopic pregnancy. Okay. Next question. Okay. So what do we do for this patient? This is a direct indication for medical management. Why? Because she is stable. Okay. She has mild pain. The size is less than 3.5 centimeter. There is no cardiac activity. So she is a perfect patient for a medical management. Okay. 1 second. Let me go to directly here. Okay. A 22-year-old primigravida is overdue by 2 weeks. Okay. She visits the OPD with complaints of bleeding and abdominal pain on the right side. On examination, her vitals are stable. Examination is unremarkable. A bimanual examination reveals a bulky, soft uterus with no tenderness and no adnexal mass. Bleeding is present. Beta HCG is 1400. Ultrasound is normal and both the adnexae are normal. So here we have a situation of a pregnant patient again. Okay, UPT is positive. They mentioned primigravida here. She's overdue and beta HCG is there. So she's definitely pregnant. Okay, and she has symptoms of pain and bleeding. Okay, and the ultrasound is normal. Okay, so what is this? What do we call this? This is called a, yes, the correct answer is A. But what is this called? She's pregnant, but nowhere can I see where the pregnancy is because the scan is normal. This is called a pregnancy of undetermined location or a PUL. Pregnancy hai, pata nahi kahan pe hai. We don't know where it is. So it's either a very early pregnancy, okay, or it is an ectopic pregnancy, or it is a failing pregnancy. Okay, so what are the options? It is either an early pregnancy in such a situation, or it is a failing pregnancy, or it is an ectopic pregnancy. That is what either of it could be. Okay, so what do we do if such a patient comes? हमें कुछ नहीं दिख रहा, ठीक है? हमने beta HCG करा लिया, ठीक है? कितना आया? 1400 आया. When will we repeat the beta HCG? We will repeat it after 48 hours. Why? Because this is called as doubling time. What does this mean? This means that beta HCG in early pregnancy, in a normal intrauterine pregnancy, if the pregnancy is normal intrauterine, beta HCG will double. Double is again a misnomer. The rise should be more than 60% in 48 hours. Okay. In a early normal intrauterine pregnancy. So what do we do if we get such a situation? We have to repeat the beta HCG after 48 hours. Okay. And see if it is doubling or if the rise is more than at least 60%. Agar ye ho raha hai, we are happy because this means it is a normal intrauterine pregnancy. It's just too early. That's why we can't see it on the ultrasound. When are we able to see it on the ultrasound? Something called the discriminatory zone. What does that mean? Discriminatory zone means that only after it is above 1500, the beta HCG value, can I see the pregnancy on a transvaginal scan. and only if it is above 6,000 can I see it on a trans abdominal scan. Okay, so TVS 1500 के ऊपर, trans abdominal scan में 6,000 के ऊपर I will be able to see the pregnancy. उससे पहले I will not be able to see, and this is for a normal intrauterine pregnancy. So there are two concepts in a PUL. One is doubling time and one is discriminatory zone. Doubling time means that every 48 hours in early pregnancy, in a normal growing pregnancy, the value will become more than 60%. So if it's 100 today, day after tomorrow, it should be 200 or at least more than 160. And it keeps increasing like this. And when will I be able to see the sac on the ultrasound? Once it crosses 1500 on our TVS. Remember, TVS, we see things earlier. And 6,000 on a trans abdominal scan. Somebody is asking, why not C? Okay, repeat scan after 3 days. Yes, that's also a possibility, but I do not want to. What can I do right now? What is an earlier thing I can do? An earlier thing I can do is after 48 hours itself, I can be relatively convinced that this is an intrauterine pregnancy. I'm not saying this is wrong, okay, because after, if it's a normal pregnancy, after 3 days, this should cross 1500. You're right, okay. But a better answer would be repeating the beta HCG after 48 hours. This will give me a clue that I'm not dealing with something like an ectopic pregnancy or a failing pregnancy, okay. And I might have to repeat my scan even earlier, okay. So this is the more appropriate answer. They are trying to here ask you what is pregnancy of undetermined location and how you manage this. Remember doubling time, remember discriminatory zone. Okay, next question. 28-year-old woman has been on OC pills for 5 months. She presents to the OPD with 6 weeks pregnancy. UPT is positive. What is the most accurate method to determine the gestational age in this woman? I think we all know this. The most accurate way is by the most accurate way in the first trimester is, of course, what we call the dating scan, where we measure the crown rump length. Okay, the crown rump length is basically we measure the fetus, the length of the fetus, and the software in the ultrasound machine will calculate and give us a period of, gestation. Okay, so remember CRL is the best way to determine the gestational age. Don't get confused by OC pills, okay, by other things, okay. All other things can be done, but the best way is asked. The most accurate method is a crown rump length. Okay, this was a nice question. This is a clinical question. This won't be given in your books. Okay, this comes from actually working in the labor room, and that's what the shift is going to be now. They're going to ask a lot of practical questions, is what I feel. Okay, and we are there to help you answer these better. Okay, so following delivery, just a sec. Okay. Following delivery, the placenta is being removed by traction on the structure shown. So what is the structure shown? What is being done? A controlled cord traction is being done. Okay. And then the structure snaps. This snaps, the cord snaps. Okay. And this happens very commonly in the labor room. Okay. What happens is before separation has happened, we start pulling on the cord. Okay. We start doing controlled cord traction. And that results in snapping of the cord. So what is the next best step? Should we give oxytocin? Should we massage the uterus? Should we do Creed's method? What is Creed's method? We'll discuss. Or should we do a manual removal of the placenta? Yes, so most of you have answered correctly. You will do a manual removal of the placenta. So all the rest also will go, some of them will go. So oxytocin will also go hand in hand. Okay, oxytocin also we will, and this would have been started earlier also, because as part of AMTSL, this should have been given. If not given, give oxytocin. But the best answer here is you put your hand in, okay, and you remove the placenta and take it out, because you've lost the cord. You can't find the cord has snapped. Okay, so the best way to remove the placenta is take it out and then do uterine massage. Creed's method is never done. Okay, Creed's method is basically giving fundal pressure on the uterus. This used to be done many decades earlier. Okay, and that will lead to expulsion of the placenta and many times uterine inversion also. Okay, so this is never ever done. Creed's method is now outdated. Manual removal of placenta is what is done. Okay, so you'll find a lot of these messages in between. Okay, so everything seems very hard at first. Okay, but remember, it gets it gets easier. I won't say very easy. Over time, it gets easier and easier and easier. Okay, it's very easy for me to say all these things. I know it's with so many subjects and with the exam very nearby, it gets a lot of tension is there. But remember, keep it in your mind. It will eventually get easier. Okay, so just hang in there. Since we talked about Creed's method, let me just take you through Leopold, the different obstetric maneuvers which are commonly asked. Iska image always comes in some exam or the other, it will come. Okay, the grips, what we commonly call the grips in our clinical examination. Okay, what is the first grip? This is the fundal grip. This determines the okay, somebody is saying not to sound unprofessional, but the kind of like the kid's voice. So my daughter has slept, but my son is yet to sleep and he's roaming around. So you might see, you might find him coming in between. So, okay, so fundal grip is we palpate the fundus, okay, and see what part is occupying the fundus. Okay, then what do? Then we do the lateral grip. This is the second Leopold's maneuver where we see which side in a longitudinal line, which side is the back, which side is the limbs. Okay, then this is the first pelvic grip. Okay, the first pelvic grip is done to determine what part occupies the, or what is the presentation, what part occupies the lower pole of the uterus. And this is the second pelvic grip. Okay, where we turn our hands facing the feet of the patient and then we try to approximate our hands. Okay, and see, this is basically done to see if the presenting part has entered the pelvis or is still above. Okay, so if our hands are approximating, that means the head is above. If we're not able to approximate our hands, the head has entered the pelvis. Okay, you may think these are questions for your final year university, clinical viva, all that, but these come as images. So it's very important to know these questions also. Okay, so this is the third grip. This is the fourth grip. This is also called as Pollock's grip. Okay, so fundal, lateral, first pelvic, second pelvic grip. Okay, what is modified Ritgen's maneuver? Some of these have come as questions, some have not, but I just thought I'll take you through all of these quickly. Modified Ritgen's is controlled extension of the head. So when the head is born, how is the head born? By which mechanism of labor? By the mechanism of extension. The head is born by extension. So sudden extension, when it happens, it can cause perineal tears. So what is done is a controlled extension is done. So you can see one hand is allowing a controlled extension and the other hand is giving perineal support. Okay, so this prevents perineal tears from happening. Okay, so this is controlled extension. So you have extension and the other hand is giving support. Okay, somebody is saying, okay, when you're holding with the spirit indicator team. Okay, thank you so much, Aditya. Thank you so much for that. Okay, let's continue. So this is controlled extension with pelvic support. Okay. What is Pinard maneuver? Okay, now coming to the breech maneuvers. What is Pinard maneuver? Pinard maneuver is basically done in when we do a total breech extraction. That means we put our hand in and we grab the feet of the baby. Here we are putting our hands in the popliteal fossa so that the leg gets extended and we can take the leg out. Okay, it is used in total breech extraction. It is a maneuver to take out the leg of the baby. What is Lofset maneuver? Lofset maneuver is done in assisted breech delivery. Okay, so remember there are three types of breech delivery. One is spontaneous breech. Dismay, we don't do anything. The baby comes out by itself. It is seen in very preterm babies. Then we have assisted breech delivery, where you have most of the maneuvers. And then you have total breech extraction. That means we put in our hand and take the whole baby out. We will discuss where this is done. But most of the maneuvers are for assisted breech delivery, where most of the baby comes out, mainly the after coming head we have to help. Okay, what is Lofset? Lofset is for releasing the shoulders. If the hands are like this is done for that. Okay, Burn Marshall is for after coming head. Okay, look at the image and this is how it's done. This is all you need to know. Okay, what is done here? This hand is giving suprapubic pressure to maintain flexion, and with these hands you sweep the baby over the abdomen. Okay, then what is this? Morisot smelly viet. This is again for after coming head of the baby. Okay, so here again what is being done? The suprapubic pressure is being done. Apart from that, the main maneuver is this hand is promoting flexion from on top, and here this hand is causing flexion by the malar eminences pe finger rakhe. It's trying to flex the head. Okay. So the purpose of all these is to maintain flexion. Okay. And not let the head get extended. Head extend ho gaya to bahar nahi aayega. It has to maintain flexion. The best way, however, is Piper forceps. For maintaining flexion, the name of forceps we use for delivering the aftercoming head is called a Piper forceps. This is the best way to maintain flexion of the head. Okay. What is Prague maneuver? Prague maneuver, it's never been asked, but I thought I'd tell you. It is if you've seen normally kya hota, the back is anterior. Kabhi kabhi kya hota, what happens sometimes is the back goes posterior. No matter how you try to keep it anterior, it goes posterior. In such a situation, what should you do? You should do this maneuver. Again, this is again trying to maintain flexion. This is called as Prague maneuver. If the back becomes posterior in a breech delivery. Okay. What is this? This is Bracht maneuver. Okay. This is again, this is a way of delivering the head in a breech delivery. Okay, I won't go into too much because these are not very important. Okay, let's go to something which is more important. This has come as a question. Mac-Roberts maneuver. What is Mac-Roberts maneuver? Mac-Roberts maneuver is used in shoulder dystocia. Okay, shoulder dystocia means what? The head has come out, but the shoulders are impacted. The shoulders are unable to come out. So what do? You do Mac-Roberts maneuver. What is this? This is flexion, hyperflexion at the hip joint. Okay. And so you make the patient, you suddenly hyperflex, okay, the hip joint, and this will lead to release of the shoulders. Okay. At the same time, suprapubic pressure is being given. Okay, so this is hyperflexion at the knee and the hip joint will release the shoulders. This is Mac-Roberts maneuver. If Mac-Roberts maneuver and suprapubic pressure fail, what should you do? You should do what is called as Rubin's maneuver. What is Rubin's maneuver? This is moving the anterior shoulder, putting your hand in and trying to dislodge the anterior shoulder. So this is the next set of maneuvers for shoulder dystocia. Okay, so first was Mac-Roberts. If that fails, then Rubin's maneuver. If that fails, then Wood's corkscrew maneuver. So what we do is we tried anteriorly to move the shoulder. Now we try posteriorly to bring the shoulder anteriorly. That is called as Wood's corkscrew maneuver. Okay. What is Gaskin's maneuver? This is also in shoulder dystocia. Okay, so here the woman is kept on asked to lie down in an all fours position. Okay, and that sometimes releases the shoulders. Okay, and lastly, if nothing else works, then is Zavanelli maneuver. What is done here? The head is pushed back inside and a cesarean section is done. Okay, so this is you rarely have to resort to Zavanelli and all these, but you should know the order. The first thing you will do is Mac-Roberts and suprapubic pressure. Okay, if these fail, then you enter the rotational maneuvers, that is Wood corkscrew and Rubin maneuver. Okay, if these fail, then you go to Zavanelli and Gaskin and the others. Okay, so the order you should know. The first thing is Mac-Roberts, suprapubic. If that fails, then the Wood's corkscrew maneuver is done. What is Brandt-Andrews technique? Brandt-Andrews technique is removal of the placenta. Okay, by controlled cord traction. That means traction on the cord and counter traction on the uterus to prevent uterine inversion. Okay. The placenta can come out by two methods, either shiny schultz. Shiny schultz is when the center comes out first and you see nice shiny fetal surface on top. Dirty Duncan is when the side laterally it separates first. So the maternal cotyledon surface appears first. That is called as Dirty Duncan. It's very easy to remember. Shiny schultz is the fetal surface. Dirty Duncan is the maternal surface. Okay, the fetus is nice and shiny. You can remember it that way. Okay, and the mother is full of blood. So Dirty Duncan, cotyledons will be there. Okay, Zavanelli procedure is considered an emergency. Yes, Zavanelli procedure, I have honestly never seen it being done because most of the time some maneuver or the other works. But yes, we have heard about it. And what is done is the head is pushed back. It's a last resort procedure. Zavanelli is when nothing else has worked. Okay, you push, and by that time, usually the baby is dead. It's a last resort maneuver. The head is pushed back and a cesarean section is done. Okay, let's go to the pelvis and the skull. Okay, because this is another commonly asked area. Okay, so we'll discuss the pelvis and skull. Question is, identify the plane colored green. Okay, so what is this green area? Is it the inlet? Is it the cavity? Or is it the outlet? It's very easy, I think. This is the plane of the mid cavity. Now remember, we have the inlet. Okay, we have the mid cavity. Okay, this hole is the mid cavity. At S2, S3, we have the plane of greatest dimension, and at S4, S5, we have the plane of least dimension. These are the two planes in the cavity. Okay, the plane of least dimension is also the most constricted part of the pelvis. So it's the most constricted part and the place where most fetuses get stuck. So it is where obstructed labor happens and deep transverse arrest happens at this plane. It is also the plane of the ischial spines. It is also called as zero station. So all this is important. Plane of least dimension, the word itself tells least, smallest part of the pelvis. क्या क्या होता है इस पे? जीरो स्टेशन होता है, ischial spine होता है, deep transverse arrest हो जाता है. Okay, so easy way to remember this: plane of least pelvic dimension. Okay, remember L for least. Okay, it is the narrowest. Levator ini origin is at this place. Okay, P for the curve changes at this point. Okay, so the curve changes from here, it turns like this. Okay, this is called the curve of Caras. The curve of the pelvis changes here. This is where we give pudendal nerve block. So you have two L's, two P's, and then this is where deep transverse arrest happens. Okay, DTA. This is where internal rotation and the mechanism of labor. This is where internal rotation happens. And remember, zero station also, Z. Okay. So least pelvic dimension, this is the importance of this plane. This has come as a question, some form or the other earlier. Okay, so it's very important to mention plane of least pelvic dimension. Least means narrowest, also levator ani, pudendal nerve block is given here, change in curve of the pelvis. DTA and internal rotation happen at this plane. Okay, we've already discussed the types of pelvis. I won't go here. I'll quickly take you through the definitions because I want to quickly discuss some important points. Okay, so what is lie? Lie is longitudinal axis of the fetus to the axis of the mother. So you can have longitudinal lie and you can have an oblique lie, or you can have a transverse lie. Okay, now what is presentation? Presentation is the part of the fetus that is occupying the lower pole of the uterus. So you can have a cephalic presentation, you can have a podalic or a breech presentation, and you can have a shoulder presentation in transverse lie. Okay, now there's certain other things and I've put them all together because this is where I will be discussing diameters of the fetal skull and how to remember them easier. Now to make things simpler, in cephalic presentation, in cephalic, all these four you see are cephalic presentation, right? So the presentation here is cephalic. Okay, and what is changing? But the attitude is changing. Okay, the attitude means the degree of flexion or extension. Okay, so here you can see it is well flexed. The attitude here is well flexed. Here it is deflexed. Here it is partially extended. Here it is fully extended. Okay, is this part clear? Now, in a well flexed head, what do you mean by presenting part? So when I do a PV, the part I'm feeling is called the presenting part. Okay. And I describe the presenting part by a term called the denominator. Okay. So in a well-flexed head, the presenting part here is the vertex. Okay. And the denominator is the occiput. The same for a deflexed head. That means the head is neither flexed nor extended. Here also vertex, occiput. In a partial extended head, what is the presenting part? The presenting part is the brow. Okay. And the denominator is the frontum. Okay. In fully extended head, the presenting part is the face and the denominator is the chin or the mentum. So remember, face or brow जब हम बोलते हैं, ये presentations नहीं है. They are presenting parts. It's a misnomer. Okay. They are presenting parts. Now, what is important? इसमें से आपको क्या learn करके जाना है for your exam is the diameters. Now, there are two diameters in the head. One is the transverse diameter, which doesn't change irrespective of flexion extension कितना हो रहा है. The transverse diameter is the biparietal diameter, which is 9.5 centimeter. This doesn't change. Okay. This is the engaging diameter. Remember this. This is the engaging diameter. It doesn't change. Whether the head is extended or flexed, it remains the same. What changes is the presenting diameter. Okay. The presenting diameter will change depending, that means the anterior posterior diameter, depending on extension or flexion, this diameter is what changes. Okay. So in a fully flexed head, what is the presenting diameter? It is the suboccipitobregmatic. ठीक है, अब इसको कैसे याद रखना? How do you remember this? Okay. When I'm crying, okay, when I'm sobbing, okay, I look down and I'm crying. So my head is flexed. I'm sobbing, SOB, suboccipitobregmatic, and this is the smallest diameter. This is 9.5 centimeter. Okay. So fully flexed head is when you're crying, you're sobbing, suboccipitobregmatic, SOB for sob, for crying, and this is in a fully flexed head. In a deflexed head, what happens? In a deflexed head, I'm looking straight. Okay. So it's like I'm working in the office. I'm looking straight ahead. I'm looking at my laptop. So what is the diameter? It is the OF, office. Occipitofrontal diameter, which is 11.5 centimeters, slightly bigger. From here to here, I'm looking straight ahead. This is the diameter. When it is partially extended, remember this is brow, this is verticomental diameter, which is the largest diameter, 14 centimeter. This cannot enter the pelvis because pelvis के diameters अगर पढ़े हो तो largest उसमें 13 centimeters है. 14 centimeter can't enter a 13 centimeter diameter. Okay, so this has no mechanism of labor. Nothing further will happen unless अच्छे से extension हो या अच्छे से flexion हो. Face में what is the diameter? Submentobregmatic. Remember, mento was mentum, chin. Okay, and this is again a small diameter, 9.5 centimeters. This is what is important for your exam. This is what can be asked. I had to tell you a bit before because it becomes difficult to understand immediately. Yes, mento-occipito in partial deflection. A verticomental is what is the, sorry, in deflection it is occipitofrontal or suboccipitofrontal. Okay, not mento-occipito. Okay, in deflection it is OF. Remember, office. Partial deflection, office. I'm working on my laptop in the office. I'm looking straight ahead. So OF, occipitofrontal 11.5. ठीक है. Deflection किसके साथ associated है? Occipito-posterior positions. Remember this. OP in deflexed head is very common. Okay. So we've discussed the diameters. Okay. Positions. So this is another area which comes in the exam. They'll give you a diagram and say identify the position. What is position? Position you basically means the relationship of the denominator to different quadrants of the pelvis. Don't get these wrong. Main आप लोग किसमें confuse होते हो? Right or left में. See how the pelvis is. Okay, many times वो R या L लिखा होगा. If it's not written, like this woman is a woman who is standing in front of me. Okay, so obviously this is her right side. Okay, my right is here, uska right wo hai. ठीक है, so this is right occipito-posterior. Small things which many of you sometimes get wrong in a hurry. Okay, so as I said, don't look at the options. First think ki iska answer kya hoga, and then you look at the options and mark the correct answer. Something which you should not go wrong, something which comes in every other paper. Okay. Next question. Okay, so this is some questions to do with this. Fully flexed head. Now, what should the presenting diameter be? Fully flexed head. I'm crying, I'm sobbing. It should be SOB, right? Suboccipitopragmatic 9.5 centimeter. और क्या क्या 9.5 centimeter है? BPD is 9.5 and also the submentopragmatic face is also 9.5. Three diameters which are 9.5 centimeters. Okay. Direct occipito-posterior is most common in which pelvis? Remember we discussed this, anthropoid. Android maybe hota hai, but more common in anthropoid. Okay. Identify the position. We just discussed this. This is the woman's right. This is her left. So this is right occipito. The occiput is posterior. So right occipito posterior. So I'm just rushing through these because these are very easy. Okay. So what will get you what you want to be? Okay. And this is from life experiences I'm telling you. Okay. Self-compassion, small wins. Congratulate yourself on a small win. GT mein achhe marks aaye. Congratulate yourself. That boosts your confidence so much that it makes you want to study more. Okay. And consistency is very, very important. Okay. You have to be consistent. This is in fact the most important, I feel, in your preparation for any exam. ठीक है, एक दिन पढ़ना एक दिन नहीं पढ़ना ऐसे नहीं. You have to be consistent every day. Put in some amount of study. Okay, unless there's some emergency. Patience. Okay, you will get, some people reach their goal earlier, some people it takes some more time. Eventually everybody will get there. You just need to have a bit of patience. Okay, moving on. Next question. Okay, this was a nice question. This came in last year's Neet PG, and I'll tell you why it's a nice question. Okay, so this is the exact question. Don't ask me how I know this is the exact question, but this is the exact question. A 39-year-old G2P1 presents at 18 weeks, 5 days for her routine targeted fetal anomaly. Okay, the fetal anatomy appears normal. Okay, see how they're just beating around the bush, building a nice premise to the question. But the cervical length is 15 millimeter. Despite being counseled that there is no clear proven benefit for the same, the patient insists on a cervical cerclage. Which of the following is a complete contraindication to cerclage? Okay, they could have just directly asked now which is a complete contraindication, but they had to nicely build a premise. This is how your clinical questions are going to come. And one more nice thing I liked about this question is they have told only short cervix is not an indication for cerclage. So they've given a message in the question. Okay, just for like the general, the thing I liked about this, whoever made this question, is that they're trying to tell you that just a short cervix is not an indication for a cerclage. Okay, but that apart, हमारा main question ये है, which of the following is a complete contraindication to cerclage? Is it a positive fetal fibronectin, membranes bulging, ruptured membranes, or advanced stage? And the correct answer is ruptured membranes. Once the membranes are ruptured, there is no point putting in a stitch. You are simply going to add on infection, and that will lead to chorioamnionitis. Okay. What are the absolute contraindications to cerclage? Remember the mnemonic 5 A's. What are the 5 A's? Number 1, any infection. Okay. Then any leaking. Okay. Any bleeding. Okay. Any, or this I won't put a normally. This is a nice way I made this mnemonic. Any infection, any leaking, any bleeding, an anomaly, or a fetal death. We'll put here only. Okay, and I'm missing the 5th A. Okay. Anyone can recall what it should be? Any infection, any leaking, any bleeding, an anomaly, and fetal death somehow should be an A. Okay, so somehow my brain has stopped working a little bit. Okay, but these are the contraindications to a cerclage. Absolute contraindications to a cerclage. If I recall, I'll come back to it. Any infection means chorioamnionitis. Any leaking, that means if she has leaked, like this question, ruptured her membranes. Any bleeding. In an anomalous fetus, there's no, yes, I remember, active labor. The 5th A is active labor. Okay. So I know how difficult it is to remember for you also. But a woman who's come with uterine contractions, you won't put in a stitch. If there's an anomalous baby or a dead fetus, there's no point putting in a stitch. Any leaking, bleeding, or infection, there's no point putting in a stitch. It won't work. It won't hold. Okay. So remember, these are the absolute contraindications to doing a cervical cerclage. Remember, bulging membranes, all these you still can try to put in a stitch. The failure rate may be higher. But in these conditions, you will never ever put in a stitch. Okay. Advanced maternal age, somebody is asking. No, advanced maternal age is not a contraindication. You can put a stitch. Age is, remember, we're all young. Okay. So the risk factors as such for an elderly gravida are higher, but it is not a contraindication to put in a stitch. Definitely not a contraindication. Okay. So these are the 5 A's you should remember for absolute contraindications to cervical cerclage. Okay, this is a question which came recently. This is another favorite topic they ask. And many of you got this wrong. The cerclage procedure not done during pregnancy is what? Is it lash, laparoscopic, worms, or Benson? Okay, and the correct answer to this, I'll wait for the answers because this was an interesting question. Okay, it's not D, it's not Benson. That's what I was waiting for. Okay, if 2 abortions, okay, somebody's asking 2 abortions. I'll come to you. I'll come to the indications of cerclage also. The answer is lash. Okay, remember, lash is a very rare procedure, but it is amongst all of these, it is one which is never ever done in pregnancy. Okay, let me take you through the cerclage procedures. We have transvaginal procedures and we have abdominal procedures. Okay. Now, cerclage pehle kisne karte? Somebody is asked, who do we do a cerclage in? If she has cervical insufficiency. So if she's had one or more mid-trimester abortion or a preterm baby with a short cervix, there is a history of a previous preterm loss or a mid-trimester loss, then we will put in a cerclage. Only a short cervix or only a history of a mid-trimester abortion, no, it has to be both together. Okay. So what are the transvaginal procedures? This is an I&I question, you're right. I put it here because I thought you should know, it's a very important question. Transvaginal procedures are, and the most common is a McDonald procedure. Okay, this is the simplest one, the one we all know, also called a purse string suture. It's like how you have the potleys where you just pull both the ends and the bag closes. The cervix will close up. So this is the cervix. The stitches are put like this. Okay, and this is how a McDonald cerclage is done. Okay, also we have Shirodkars. Shirodkars is at a little higher level. So you have to separate the bladder and then put the stitch, but it is also done transvaginally. Okay, and it is done in case of failed McDonald's. Okay, so this is how Shirodkars is done, a single stitch throughout, but at a higher level. Okay, now remember, both are done in pregnancy. And when do we do it? Usually at 12 to 14 weeks is done. So once at the end of the first trimester is the best time to put in a cerclage. Okay. What are the other? We have something called as worms. Worms is similar to McDonald. We put in 2 stitches, one like this and one like this. Okay. It's similar to McDonald. Lash procedure lash procedure is not actually a cerclage also. It is basically done in between pregnancies. A defect. So it's been postulated by some people that there's a defect in the cervix. So that defect is from the cervix is cut off and that part is resutured. Okay, so sutures are put back in. Okay, and remember, this is never ever done in pregnancy. Okay, it is done always in between pregnancies. It is a procedure done very long back. Aajkal koi nahi karta lash procedure. It used to be done many decades back, I would say. Now it's not done, but it is never done in pregnancy, and the sutures are never removed. All these 3 will remove the sutures once she reaches term. Here you won't remove the sutures. So sutures not removed. What do we have in transabdominal cerclages? What are the types? We have Benson. Okay, Benson is the person who first described cerclage by a laparotomy. Okay. And we have the laparoscopic procedures. Okay. Now remember, these are preferably done in between pregnancies, inter-pregnancy period mein. But they can also be done in pregnancy. Okay, they can be done in pregnancy, especially in an emergency situation. They can be done. I have seen them being done. Okay, but in between pregnancies, they are preferred to be done. Okay, so this is also important to remember. So transvaginal, transabdominal. When do we do a cerclage? Short cervix plus a history, bad history is then when we do a cerclage. Okay, next question. A 34-year-old primey with jaundice and a high BP, her investigation reveals a raised serum bill. This is raised. SGOT, SGPT is raised. LDH is raised. Remember, more than 600 is raised. Platelet count is less. Okay, so this is a very straightforward question. What is the answer? High BP with evidence of hemolysis. Why hemolysis? Because LDH is raised. With elevated liver enzymes because SGOT, SGPT is raised, and with low platelet count. So this is HELP syndrome. Very, very straightforward question. And it's also given that KFT and coagulation are normal. So you can easily rule out acute fatty liver of pregnancy. Okay, so it's a very straightforward question, high BP. Okay, now important to remember in HELP syndrome is an indication for immediate termination of pregnancy. Immediate termination of pregnancy has to be done for HELP syndrome, irrespective of period of gestation. Okay, it's one of those categories where you can't wait. Okay, even if she's less than 34 weeks, immediate delivery is the rule. Okay, remember this. Now, since this patient came with jaundice, okay, what are the causes of jaundice in pregnancy? Let's quickly do this because many of these interchangeably come. We have hyperemesis gravidarum, we have intrahepatic cholestasis of pregnancy, we have acute fatty liver, we have HELP, and we have viral hepatitis. The most common cause of jaundice in pregnancy is hepatitis. So most common cause of jaundice in pregnancy is viral hepatitis. Hyperemesis kab hota hai? We all know this in the first trimester. Okay, all the rest, viral hepatitis can happen anytime, but these three occur in the third trimester mainly. Intrahepatic cholestasis or obstetric cholestasis, acute fatty liver of pregnancy, HELP syndrome usually happen in the third trimester of pregnancy. Okay. Primary symptom of hyperemesis will be nausea and vomiting. In intrahepatic cholestasis, the primary symptom is pruritus over the palms and the soles. Classic history is pruritus in the palms and the soles. Acute fatty liver of pregnancy has a vague presentation. Okay. Usually hypertensive. Again, I'm saying usually hypertensive, common in twin pregnancies, mothers with twin pregnancy. Symptom kya hota hai? Symptom hota hai jaundice, pain, and general constitutional symptoms, feeling of unease, malaise, vomiting. Okay. But pain is a common symptom. Jaundice is a common symptom. Usually third trimester, they're usually hypertensive, twin pregnancies. So these are the clues. So when you get your clinical question, look for these clues in your question. Jaundice in pregnancy, look for the other clues. Okay. HELP syndrome, you know, they will be preeclamptic most of the time. They will have signs and symptoms of preeclampsia. Viral hepatitis will have other constituents, will have history of fever or malaise or vomiting. Okay. ASTLT is mildly elevated here, mild increase. IS in hepatic cholestasis also mild increase. AFLP, they can be increased significantly. Okay, same with HELP. Okay, and in viral hepatitis, they are increased manifold. Okay, so here is where you will find them in thousands. So if your SGOT, SGPT is in thousands, think of viral hepatitis. In hundreds, think of these two. Okay. In these two, they are mildly raised. Okay. Bilirubin is highly raised here. Okay. In obstetric cholestasis is raised, but not too much. Here also raised, but not too much. I would put it something like this. Okay. KFT, you will find deranged in which of these? You will find KFT deranged here. Okay. You will find KFT deranged where else? Not here. Where else? KFT will be deranged here also. Okay. Here you may find, okay, KFT may be deranged if there is associated renal picture. So if preeclampsia with renal failure, you may find it raised. Okay, here it won't be raised. Okay. Hematology, what's important to know here, you will have reduced platelet count. Here you will have a picture of DIC. Okay, so AFLP is one of the bad ones. AFLP, what is the treatment? You will immediately terminate pregnancy. HELP syndrome, immediately terminate pregnancy. Okay, in obstetric cholestasis, you will terminate pregnancy at 38 weeks. Okay, so this is what you should take home from this slide. You can get clinical questions on any of these. Obstetric cholestasis commonly asked, HELP, AFLP, you should know how to differentiate. Viral hepatitis, most of the time it's very clear-cut. Hyper-MS is also very clear-cut. History will be vomiting in the first trimester of pregnancy. Okay, another question. A 34-year-old G2P1 presents at 35 weeks. She has no complaints and is appreciating fetal movements well. She has a previous, now let's look at the clues. So this is how the questions are formed. She has a previous classical cesarean, okay, at 25 weeks for eclampsia and severe fetal growth restriction. So what is important? She has a preterm cesarean, which was a classical. What do you mean by classical? This is the uterus. Normally we give an incision like this on the lower segment, but here she's been given an upper segment incision. Okay. Why was it done? Because in a preterm baby at 25 weeks, the lower segment is not formed. So any incision you give on the uterus, it is in the upper segment. Okay. For eclampsia and severe growth restriction. She is currently on aspirin and vitamins. On examination, the uterus is, the SFH is 38 centimeter. That means it's a term uterus. Fetal heart is good. Ultrasound is a single live fetus in breech. So that's the other clue. Breech. Okay. Placenta posterior, amniotic fluid normal. The patient desires a vaginal delivery. What is the best option? So now many students asked me when this question came last exam is, and the correct answer, yes, most of you have got it, is schedule an elective LSCS at 37 weeks. The patient may say, ki, I want a vaginal delivery. And this is where they are trying to trick you by saying she desires a vaginal delivery. Remember the 2 points going against it. And the most important point going against it is a classical cesarean. Classical cesarean is a contraindication to a vaginal delivery. The patient has to be, the patient will say, I want this, but it's your job as a doctor to tell her, no, it's not safe at all for you. Okay. And it is best we do a cesarean section. So they will try to trick you into answering, marking the wrong thing. So many of you marked ECV, okay, or review a scan after 2 weeks. This won't matter. Reviewing a scan won't change things, even if it becomes cephalic, even if I manage to do an ECV. Okay. First of all, I won't do an ECV because the scar on the uterus is a relative contraindication. But even if I do an ECV and if it's successful, there's no point because I will still do an elective LSCS. So remember, the clue, the biggest clue is classical. If you see the word classical ka history hai, remember the risk of rupture is of 5 to 10%. Okay, that means 1 in 10 mothers will rupture the uterus. So it's very, very high. Okay, so you have to do a cesarean section. Okay. This is one of my patients, okay, with a rupture uterus. This is what we are worried about. We're worried about the uterus rupturing. Okay, that's why we can't afford to give her a normal delivery. Okay, next question. Primary presents, okay, ECV is also a contraindication in previous classical. Somebody is asking. So if you go through the books, and I've gone through many books, previous scar on the uterus is given as a relative contraindication, not an absolute contraindication. That's why I'm saying even if I do an ECV, okay, and even if it's successful, there's still no point. Okay, so that in a way classical then becomes a contraindication because there's no point, an absolute contraindication, because there's no point doing the ECV in the first place. Okay, primary gravida 40 weeks. She has been in labor for 3 hours. Which of the following determines she is in active labor? Okay, so active labor ka definition has now changed. It's very important to remember this. The WHO now says it is more than 5 centimeters. Pehle kya tha? When we were postgraduates, it was 3 centimeters. Then it became 4 centimeters when we finished our post-graduation. Now the ACOG says 6 centimeters, and this is your Williams. Okay, but the WHO says 5 centimeters. In 2018, this happened. The WHO says 5 centimeters. The ACOG says the new active labor starts at 6 centimeters. this is very important to know that the definition of active labor has changed. Again, I will repeat this. It is very, very important. WHO says 5 centimeter. Okay, ACOG, our American guide, the American guidelines say 6 centimeter. What we follow is WHO, because many of the major medical colleges in India, okay, if you talk about Safdarjung, Maulana Azad, at least the Delhi medical colleges I know, are following the new WHO partograph, which is called the Labor Care Guide. Okay, and I will take you through this because it is an expected question. तो पहले क्या था, partograph था, उसपे 4 centimeter था. Now it's changed to the next generation partograph, which is called the Labor Care Guide. इसमें 5 centimeters पे है. Okay, so that's why here they're not asked. Okay, in the exam, they will ask you, if you get a question on partograph, they will tell you, the question will be mentioned, the WHO modified partograph, which is what we have been always following, or they will ask you questions specifically, they will mention labor care guide, which is the new partograph. Okay, so partograph and its changes. Okay, let's just go through the main things in this. This is what was the earlier partograph, which we all know. 4 centimeters pe alert line is there. Okay, and this is plotted at the rate of 1 centimeter per hour. Okay, I'm going a bit quickly. If anyone wants me to slow down, let me know. Okay, so 1 centimeter per hour is the alert line. Okay, and remember, when a patient comes in labor, and this has come as a question, when a patient comes in labor, say she comes at 6 centimeters. Okay, where do I plot? Where is my first marking going to be? The answer is the first marking is always on the alert line. So patient comes to me, say at 5 a.m. in the morning, my first marking will be on the alert line. So this is 5 a.m. This is 6 centimeter. Why do I mark on the, I start my marking on the alert line? Why? Because I don't know usse pehle uska progress kaise tha, where she's come from, what has happened. Has she gone to some other doctor before coming to me? How long was she at home in labor for? I don't know. So I presume that I'm starting with her at on the alert line. So I won't mark it here. Remember, it is never marked there. It is always marked. The first marking is always on the alert line. Many of you get this wrong. This has come as a question earlier. Okay. First marking on the alert line. Okay, and we're talking about the old partograph, Abhi, because many places are still following the old partograph. Many of your questions in the exam may come from the old from the old question bank which the national board has. Okay, and many questions are still on the WHO modified partograph, which is still being followed, but some colleges have switched over to WHO labor care guide, and that also may come. That's why I'm trying to tell you both. Okay, so somebody's asking, are you Maulanian? No, I'm not Maulanian, but I am from this. I have done my MBBS and post graduation from KMC Manipal many years back. Okay, it's been 15 years since I passed out my post graduation, but I have worked in Lady Hardinge Medical College as an assistant professor for many years. Okay, I am actually a Delhiite, and then I worked for many years in the south in Mangalore, then in KMC Mangalore as a faculty, then in Lady Hardinge as a faculty, and more recently I am a visiting professor at ESIC Faridabad Medical College. Plus I am heading the unit, for those of you who just joined, I am heading the unit here in a hospital in Faridabad. Okay, so so I'm very familiar with Delhi colleges because I have worked as faculty here. So that is why I know what's happening here. Okay, so so what we do is we mark on the alert line, we mark the first, when she comes to us, that is anytime after 4 centimeter, we start the plotting on the alert line. And then the alert line, remember, is plotted at the rate of 1 centimeter per hour. इससे जल्दी डिलीवर हो जाना चाहिए पेशेंट को. This is like the extreme. इससे ज़्यादा, so anything on the left of the alert line is normal. कुछ भी यहाँ पे आएगा, it is normal. Okay, suppose she came at 5 a.m. she was 6 centimeters, and then after, usually we repeat a PV after 4 hours. Okay, so at the rate of 1 centimeter hour, she should be 9 centimeter at the end of 4 hours. So 5, 6, 7, 8, 9 o'clock when I see her, she should be 9 centimeters, right? But I find she is, say, she is 6 centimeters. So sorry, she came at 6. At the end of 4 hours, she should be fully dilated. She should be here at the end of 4 hours. But I find that she is, say, 7 centimeters. Okay, so I plot the line here and I join. I now find that she has crossed the alert line. So now my warning bells start ringing. I get concerned that this patient is not progressing how she should progress. In 4 hours, just 1 centimeter she has increased. Okay. By now she should be fully dilated. Okay. So what should I do? I should now find the reason. Why is she not progressing? Are contractions less? Is there cephalopelvic disproportion? Is it occipito-posterior? Is it face? Is it bro? What is the reason? Okay. And then do your corrective measures and then see after another 2 hours or 4 hours or however her progress is, if it's crossing the action line. Okay, action is when you are now, you have to deliver her. Labor has been so long that I can't wait anymore. And if she's still 6-7 centimeter, I will do a cesarean section. Okay, there's no point waiting any longer. After it's crossed the action line and she's not yet fully dilated, the best way is to do a cesarean section. Okay, so this is what you should know from the WHO modified partograph. Alert line, 4 hours to the this side is the right side of the alert line. Of the alert line is the action line. Okay, and 1 centimeter per hour is the marking of the alert line. Okay, so this is how the partograph. This is the old one. So this is the simplified partograph. ये हमारे PG time में होता था. क्या होता था? Latent phase was also marked. Okay, can you see this? Then this was removed. Okay, because nobody knows how long latent phase has been going on for, right? Latent phase means 0 to 4 centimeter as per the old definition. Okay, so this was the old partograph or WHO simplified partograph. Then came the new partograph, what we have just been discussing. No latent phase, active labor starts at 4 centimeters. Okay, this is what we've just discussed. Okay, then beech mein WHO ye bhi laya tha. Many of you would not know this. This is called the color coded partograph. This was for use in primary healthcare centers. Color code kar diya because taki it's easy for illiterate people who are birth attendants who can't plot graphs to understand green, yellow, and red. Okay, and this is the new labor care guide. थोड़ा blurred है, मैंने zoom करके individual portions दिखाया है. This came in 2018. This is being followed. Remember, this is a very, very potential region from where your questions can come. ठीक है? This is called the next generation partograph. Okay. Now, if you want a detailed lecture on this, it's on my YouTube channel, but I will quickly take you through the important points because this is a revision class, what you need to know. Okay, so dissecting the modified partograph, इसमें ये सब नहीं है, ठीक है? ये पुराना है, ये पुराने examples है. Okay, coming to the next generation partograph. Okay, so remember 6 is the new 4 as per the ACOG, but for the labor care guide, we are using 5 centimeters for active labor. This is the first important thing you should remember. Okay. The second important thing is that this labor care guide came into being because of something called as respectful maternity care. Okay. Respectful maternity care. Okay. What is this? This is a very important topic again. Those of you who worked in government labor medical colleges in the labor room, you would have seen the status or how women are treated there. So this, the government and the WHO, not only in India, in many other countries, that mothers have to be treated with respect. Okay. And labor has to be a very enjoyable process. Okay. So what the WHO has now said is that because 2 things have happened, we have to respect the mother, and because 5 centimeters is the new active phase, we have to change our thinking. Okay, so the labor care guide has 7 sections. Okay, identification hai. This section is completely new. Supportive care. Does the mother want pain relief? Does she want somebody to be with her? Okay, so supportive care or respectful care is the new thing. It has been found that 1:1 care improves the progress of labor. Every pregnant woman gets 1 attendant with her, should be encouraged. Okay, then care of the baby, care of the woman, labor progress, medication are same. Okay, and this is again old. Okay. Just hold on. I'm getting a call from the labor room again. Just a second. Huh? Okay, sorry. Okay, so where were we? Okay, so this is how the labor care guide looks like. Okay, it looks confusing. Okay, don't get too worried because it's something new. Just remember that the supportive care is new. Okay, and in the supportive care, you have things like companionship, pain relief, oral fluids, posture. Okay, so these are some things which are. So, what are the things you should encourage? You should encourage companionship. You should encourage the woman to ask for pain relief. You should encourage hydration, and you should encourage a mobile position. She should keep moving around. Okay, otherwise the things are the same. Okay, supportive care, care of the baby, fetal heart, all that is the same. Okay, care of the woman. What has now changed is the 5 centimeter rule. Okay, and I'll directly come to that. Okay, this is what has changed. Okay, so जो पहले ग्राफ हम प्लॉट करते थे सर्वाइकोग्राम, all that has been removed. Okay, what the WHO now says is that, see this column here, it says that 5, can you see here, 5, 6, 7, 8, 9, 10. Okay, this is first stage of labor from 5 centimeter onwards. Okay, one new thing which has been added is that the second stage is also, can you see this new thing here? Second stage be included. Okay, in the old partograph, second stage was not there. Here they have put second stage also. Okay, so this is one change, one more change. Now look here, at 5 centimeters written here, 6 hours, at 6 centimeter, 5 hours. So what does this mean? This means that if she is 5 centimeters, I can wait for 6 hours. Okay, that is my cutoff. Beyond 6 hours, I need to get worried. Okay, also we have to keep other things in mind. As long as the mother is fine, she has no signs of distress, fetal heart rate is okay, we can wait up till 6 hours if she is 5 centimeter. If she is 6 centimeter, we can wait up till 5 hours. If she's 7 centimeter, we can wait up till 3 hours. If she's 8 centimeter, 2.5 hours. If she's 9 centimeter, 2 hours. Okay, so this is the new change. This is what you need to know. Okay, if you can't remember the numbers also, I don't think you're going to be quizzed on this, but you need to know that this has changed. So cutoff limits have been determined कि इतने सेंटीमीटर्स है तो इतना और हम वेट कर सकते हैं, बाकी सब कुछ ठीक होने पे वी कैन वेट फॉर, इफ शी इज 5 centimeter 6 hours, 6 centimeter 5 hours, 7 centimeter 3 hours, and so on. Okay, so this is what a change has happened. Second stage has come. Okay, and the rest is almost same. Okay, so this is a difference. In modified partograph, 4 centimeter, this is 5 centimeter. In the old one, alert line was there, action line was there. Here there are time restrictions on cervical dilatation at each centimeter. Okay, contractions is the same. There's no change in checking contractions. Here there is second stage. There is no second stage in the old one. Okay, here supportive care, companionship, pain alleviation, fluid intake, and posture are recorded. Okay, in the old partograph, everything was centered around alert line, action line. The main focus was the cervicogram. Yahan pe everything is given equal importance. So that's the difference between labor care guide and the modified partograph. Okay. Okay. So let me just see some questions. Okay. 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 So we'll go on. Okay, which is incorrect regarding the partograph. Okay, this is a previous year question based on the old partograph. Okay, so if they ask you a new question, remember they will mention labor care guide. If they ask partograph, it means the old partograph. That means the modified partograph. Okay. So alert and action line are separated by 4 hours. Yes, this is correct. Okay. Each small square represents 1 hour. Okay. This is wrong. So each small square, remember, represents half an hour. Okay. Next is send the patient to the FRU once the progression line crosses the alert line. This is also correct. Okay, because the alert line is also called as the referral line. Okay, and partograph recording should be started at 4 centimeters. This is also correct. Okay, next question. A 20-year-old primary presents to the labor room at 8 a.m. She is 41 weeks and has an uneventful antenatal period. Okay, on examination, she is 4 centimeters dilated. She is getting 2 contractions in 10 minutes. At 12 noon, a repeat PV is done, and now she is 6 centimeters. Okay, just hold on, please. My dog is crying. I think he wants something. Just hold on. Okay, so coming back to this. So she was 4 centimeters. Okay, what should be the correct answer? Anyone? Anyone? 4 centimeters. She was at 8 a.m. after 4 hours. That means at 12 noon, she's now 6 centimeters. So she is progressing at less than 1 centimeter per hour. What else have we noticed? The contractions are inadequate. What do you mean by adequate contractions? 3 to 4 contractions lasting for 45 seconds in 10 minutes is what our aim should be. Anything less than that is insufficient to cause further contraction. So what should we do? Okay, what should we do? We know the reason why the dilatation is slow. We need to augment labor. How do we augment labor? By doing an ARM or by starting oxytocin. So this should be the correct answer. Okay. And this is what the question I was saying. 30-year-old presents at 6 centimeter. Where should this be marked in the partograph? Always start marking on the alert line. That's very important to understand. Okay, and I think one last question on partograph. A 38 weeks woman presents with labor pains and contraction. She's 2 centimeters and 50% effaced. Her pulse is normal, BP is normal. What should be done next? So this is what stage of labor is she in? If we go by the old definition, even by the new definition, she is in the latent phase of labor. So what should we do? What should we do? We should do nothing. Latent phase, don't interfere. Just observe her and let the contractions increase by themselves because everything else looks fine. So we just wait and watch. Remember, latent phase, nothing active needs to be done. Okay. Okay, this is again a simple question. After how much dilatation of the cervix should she start plotting the graph? And this is, they're asking for the partograph. Okay, not the labor care guide. The answer should be 4 centimeter, 5 centimeter for the labor care guide. So remember the labor care guide now, what I've told you. Okay. So don't compare yourself. This message is just there not to make you not compare yourself with others. Okay, everybody starts at a different level. Okay, so it doesn't, I mean, in our field is such that it is very varied. You just can't compare yourself to other people. Your focus should be here, not on other people. Okay, let's continue. A multigravida is in the second stage of labor since 2 hours with good uterine contractions. On examination, the head is palpable 1/5. Fetal heart is all right. On vaginal examination, the cervix is fully dilated. The head is at the ischial spine, okay, in ROT position. So head is at 0 station in right occipital transverse and the cervix is fully dilated. She's getting good contractions. Caput is present, plus, molding is plus. So what is the diagnosis? First of all, what is your diagnosis? The diagnosis is deep transverse arrest. Okay, what is the treatment of deep? What do you do if you diagnose? What is DTA? DTA is when the pelvis, the fetus gets stuck in the transverse diameters of the pelvis at the level of the ischial spine. Remember, हमने zero station पर plane of least cavity. This is where DTA happens. So to diagnose DTA, good uterine contractions, despite good uterine contractions, full dilatation of the cervix, the head is stuck with its sagittal suture in the transverse diameter of the pelvis at zero station. So what should you do? Okay. So remember, most of the time you will have to do an emergency LSCS, more so because this patient is in obstruction. Caput is present, molding is present. But suppose caput and molding were not present, she's a multigravida. So multigravida means CPD more or less is ruled out. We can attempt a vacuum if no features of obstruction. Okay, so remember this. If obstruction is there, of course, cesarean section has to be done. No two ways about it. But in multi, especially grand multi, DTA is commonly seen. In them, it's not because of a small pelvis. It's not because of an android pelvis. In them, it's because of a deflexed head. Okay, and a lax abdominal wall. Okay, and a lax pelvic floor. So mechanism of labor is not able to happen. Okay, flexion doesn't happen, rotation doesn't happen. In such women, you can put a vacuum delivery. So I'm just telling you, DTA has two different ways of managing. Your books will give manual rotation and key lance forceps. All that is not done any longer. We either do a cesarean for obstructed labor or a vacuum for a multigravida in whom there is no signs of obstructed labor. Okay. Okay, deep transverse arrest, good uterine contractions, head at zero station, sagittal suture in the transverse diameter for 1 hour. This is also in the definition. No progress. As I said, primary or features of obstruction, cesarean. In a multi, you can attempt a vacuum. I've written rotational forceps because in some countries they do it, but for all practical purposes, it should not be done. Okay. Next question. As I said, obstetric emergencies, they always ask. So far we've had a question on PPH. We've had questions on something else was asked, ectopic pregnancy. Yeah, and we've had a question on amniotic fluid embolism. The answer to this is amniotic fluid embolism. What is this? Collapse in a patient followed by bleeding and DIC in the absence of coexisting conditions is most likely due to, it is not postpartum hemorrhage. PPH में क्या होगा? पहले bleeding होगा, फिर collapse होगा. Collapse and then DIC and bleeding. Okay, what has happened is AFE has happened and the patient has gone into DIC. Okay, so remember in AFE, characteristically there is cardio respiratory arrest and the patient will first present with collapse, okay, postpartum collapse most of the time, or intrapartum collapse, and then she will go into DIC and then she will start bleeding. So remember, the answer is amniotic fluid embolism. It is a very dangerous situation. It can happen in any woman. I have seen low risk primary gravida, multigravidas also in labor, and they suddenly just collapse and with very high mortality. Okay, it's a very sad situation. Okay, sudden onset of cardiopulmonary arrest or both hypotension and respiratory compromise. This is a table from Williams. This table is given in the new Williams. Okay, of diagnosis, diagnostic criteria to say amniotic fluid embolism. So there's sudden onset of arrest, DIC following initial symptoms happens. Okay, it usually happens during labor or within 30 minutes of delivery and in the absence of fever. Why they put this is you're ruling out sepsis as a possible cause. Okay, so no fever, onset during labor or immediate postpartum. So this is how your question will come. A patient presents, she's in active labor, ARM was just done and then she suddenly collapses. What is a possible diagnosis? Okay, so that's how your question can come. But most commonly it is following delivery, collapse followed by bleeding or DIC. Okay, so bleeding, if it happens first, it is PPH. If collapse happens first, it is always amniotic fluid embolism. Okay. Next question. Okay, a 35-year-old primey conceived after IVF, okay, came for a checkup at 38 weeks of gestation. Her obstetric history reveals she has twins, DCDA twins, okay. On examination, the first one was found to be in breech. Okay, so first twin breech and the BP is high. on 2 occasions. So you have with proteinuria. So you have preeclampsia with twins, with first twin breach. So everything is given in this question. What more do you want? Okay, what should we do next? Without looking only, you should be able to tell. Preeclampsia, why are we even waiting till 38 weeks? Preeclampsia, if it is mild, delivery at 37. If it is severe, delivery at 34 weeks. This you should all know. Mild preeclampsia, deliver at 37 weeks. Severe preeclampsia, deliver at 34 weeks. Okay. So that's one thing. We should deliver her. So the first thing you need to see is the period of gestation. Okay. Second question which comes is, how should I deliver this patient? Okay. And the answer is there. First twin breach. First twin breach, you will do a cesarean section. When? Immediately. There's no point waiting. Okay. So the answer is this. So remember, in twins, if the first twin is non-cephalic, that means first twin breach, first twin transversely, always a cesarean section. So in obstetrics, remember, in medical complications in pregnancy, two things. For every scenario in obstetrics, there are two questions you need to ask yourself. Number one, when should I deliver this patient? And number two, how should I deliver this patient? This my professor in post-graduation taught me. And this is the only thing I remember from so many classes and classes and classes. And I still tell my residents today, it doesn't matter how much good you are at surgical skills. What is important is decision making. Okay, in obstetrics. Okay, when to deliver the patient, and in your clinical scenarios, this is what the examiner wants you to know. When will you deliver? Number one, that means at what period of gestation, and how will I deliver? And there are only two ways. You can either do aim for a vaginal delivery or directly do a cesarean section. If you're able to understand these two basic concepts, okay, then you are good to go. As I said, for mild preeclampsia, 37 weeks. For severe preeclampsia, 34 weeks. So ऐसे ना सबका timeline बनाओ, ठीक है? As and when you're studying and revising, make a timeline. Okay, you have 28 weeks. Put the major goals: 34 weeks, 37 weeks, 40 weeks, and you can go till 42. And then you keep adding. Here you write severe preeclampsia. Here you write mild preeclampsia. Okay, here you can write IUGR with normal Doppler. Okay, so you can just keep putting whatever scenario you read. When will you deliver them? That's very, very important to understand when to deliver the patient. Okay. So remember two other things. If the question asks you if the delivery is before 34 weeks, so if you've decided कि मुझे 34 weeks से पहले deliver करना है, give corticosteroids. Okay, because fetal lung maturity is attained at 34 weeks. Okay, but only if you have time. ऐसा ना हो कि eclampsia patient is being asked. Okay. And you've been asked eclampsia 32 weeks and you're marking steroids. No. Okay. So only if you have time, means not in acute emergencies. Okay. So because to give corticosteroids, you need at least 48 hours. Okay. If you have that sort of time, give. But if it's an acute emergency, don't give, even if she's less than 34 weeks. Okay. If you're delivering before 32 weeks and you have time, give magnesium sulfate for neuroprotection. This is another new area which is coming up. Magnesium sulfate kahan dete? Where do we give magnesium sulfate in obstetrics? I think all of us know we give it for eclampsia, right? We also give it for prophylaxis of eclampsia. That means in severe preeclampsia, we give it for prophylaxis to prevent eclampsia. It is also used as a tocolytic. Okay, and it is also now given for neuroprotection to reduce the incidence of neurological complications in severely or very preterm babies. Okay, so if we are expecting delivery before 32 weeks to avoid neurological complications in the preterm, you can give magnesium sulfate for neuroprotection. Question. Magnesium sulfate is given in all of the above except. Okay, so remember, it is given in all these conditions. So this is the timeline I was talking about. Make your own timeline when you study medical diseases in pregnancy and keep marking when you will deliver what patient. Okay. So in hypertension, I've already told you 34 for severe and 37. Wait, 34 for severe and 37 for mild. Okay. But remember, you may have to deliver earlier. So if any of these are there, you have to deliver immediately. Okay. That is, we've already discussed, HELP syndrome is an indication for immediate termination of pregnancy. You may not have time for corticosteroids. Pulmonary edema, eclampsia, abruption, non-reassuring fetal status. These you won't have time to give steroids. They are such conditions where they are acute emergencies. Patient is bleeding. You won't sit and give her steroids. Okay, you're simply wasting time. Abruption commonly happens with hypertension. Eclampsia, you won't have time to give steroids. Okay. Fetal distress, by the time you give steroids, you'll end up losing the fetus. Okay. Or if she's pre-viable, there's no point giving steroids. Okay. Pre-viable means very early onset preeclampsia. You have to terminate because it's too long a way to reach 28 weeks or beyond. Okay. So in these, you will not even wait till 34 weeks. You will deliver immediately and you won't have time to give her corticosteroids. So this is very important. Expect at least one clinical scenario from hypertension in pregnancy. It always comes. If you open your past year papers, especially the recent ones, clinical scenarios jab se aane lage, usme hypertension in pregnancy always comes. Okay. Also remember, magnesium sulfate, agar severe preeclampsia ka clinical scenario hai, severe preeclampsia, always give magnesium sulfate if it's there in the option to prevent eclampsia. Okay, so it has to be given in severe preeclampsia. Let's do some questions now. A 33 weeks multi woman presents with a BP of 160 by 100 associated with epigastric pain, headache, visual symptoms, proteinuria. What is the next best step in the management? Okay, what is the next best step? So she is 33 weeks and she's come with severe preeclampsia. Okay, with imminent eclampsia. That means she has imminent signs. Okay, so what should you do? What is the next best step? You have to prevent eclampsia. You may think of this, you may think of this, you may think of all of them are correct. But what is the next best step? She's saying, I'm having headache. If you don't give her magnesium sulfate right now, she will have a seizure. So that's how you have to think. If you see all your questions, they always ask next best step, next investigation or best investigation. So see what has been asked and accordingly frame your answer. Okay. So many of you are writing A. Is it for this question? I don't know. Immediate cesarean karoge. Okay, ma'am, I'm not denying it. But before doing that immediate cesarean, you have to give her loading dose of magnesium sulfate. Okay. Otherwise, she will have a seizure while you're doing your cesarean. Okay. That is why next best step. In fact, all may be right to some extent, but magnesium sulfate is the best answer. I hope I'm clear. Always look for the next best step. Okay. A multipara, 36 weeks with low platelet, raised transaminases, mild hemolysis. So she is HELP syndrome. She is 36 weeks. What are we doing? We have to deliver her. Remember, we can't even wait and she's crossed 34 weeks. So nothing to worry about. We will deliver the baby. Okay. All the rest are time waste things. Okay. You will deliver the baby. HELP syndrome, anytime, any period of gestation has to be delivered. Okay. Next question, 29-year-old, 37 weeks. So don't worry if you're getting, the aim of this class is to just help you solve clinical questions. Okay. And we have previous year questions, which we're anyway discussing. I put lots of clinical scenarios and we have lots of images also coming up after this. Okay. These are what is essential now for your exam. Okay. 29-year-old, 37 weeks. BP is 130 by 90. So she is preeclamptic. Urine protein is 2+. Okay. What is the next best management? So you have to deliver her. Okay. So you will deliver her. And how will you deliver her? Deliver, she's primary, nothing else is given. So the best thing would be the next best management would be to induce labor. Very good. Okay. Next. 28-year-old primary gravida presents at 28 weeks with a headache. So she is 28 weeks and she has headache. BP is very high. Investigations reveal 2+ proteinuria, deranged LFT and platelet count. So this is HELP syndrome. See, so now different gestations with 28 weeks HELP syndrome. Again, you will deliver her only. But anything else, let's see the options. Oral antihypertensive therapy, platelet transfusion, MAG-sulf and induction of labor, or IV immunoglobulin. So the answer is you're looking for delivery. So you will give her magnesium sulfate. This will act as prophylaxis against eclampsia. Okay, because she's having headache, it will also act as a neuroprotective agent, and you will induce her. So this is the correct answer. So I hope I'm clear. Always look for clues in your answer. HELP syndrome means immediate delivery. This was last year's Neet PG question. So the question is very long, but the answer is very simple. Okay, 22-year-old type 1 diabetes in the post-op ward following a cesarean for failed induction for preeclampsia with severe features. So she was a patient with both diabetes and preeclampsia, and a cesarean was done. She now complains of drowsiness and altered sensorium. What is she on? She's on magnesium sulfate and insulin. So they are basically trying to tell you, give you clues and ask you कि ये diabetic ketoacidosis है या eclampsia है या magnesium toxicity है. इनमें से basically कि क्या है. So on examination, her pulse is okay, BP is slightly high, respiratory rate is slightly low. Auscultation reveals bilateral normal air entry. She's not bleeding, so uterus is contracted. Okay. Scar is intact. There's no bleeding anywhere. Uterus is contracted. See this. Reflexes are absent. Respiratory rate is less. Okay. What should you think of now? Alarm bells should start ringing. This is definitely magnesium toxicity. Okay. This is nothing else. Okay. Dipstick for protein and sugar is negative. So you've ruled out diabetic ketoacidosis. Okay. So I hope this is clear. I don't think I have to explain further. Questions, the questions are there to scare you. Such long questions. But if you actually think about it, clinical questions are much easier to answer than those one-word wale answers. At least that's how I feel. These are much more, but they take time. So that's what's important. Time management is very important. Okay. Okay, let's move on. I won't stop here. I think we all know this. We know magnesium sulfate is given. We know it's given as Pritchard's regime. So I won't talk much. And magnesium toxicity, we know. Okay, Pritchard's regime, if a patient is on magnesium sulfate, what are the three things we need to monitor? We need to monitor her respiratory rate. We need to monitor her reflexes, patellar reflexes, and we need to monitor her urine output. Okay. The first to go is reflexes. This came as a question in the last INI. Okay. So first to go in magnesium toxicity are the reflexes. Okay. Then the respiratory rate. Remember, magnesium does not cause renal failure. इसलिए हम output नहीं check कर रहे कि magnesium से toxicity और renal toxicity हो रहा है. नहीं. हम output इसलिए check कर रहे हैं because severe preeclampsia or eclampsia can cause renal failure. And if the patient is in renal failure, okay, magnesium will not be excreted. Magnesium is excreted by the kidneys. तो magnesium नहीं excrete हो रहा है, magnesium build up हो रहा है body में, इसलिए हम urine output check कर रहे हैं. इसलिए नहीं कर रहे हैं because magnesium is renal toxic, okay, or nephrotoxic. Please remember that's why we check output. Okay. This was a question in last to last Neet PG. Which of the following will you see long bone fractures in the fetus on antenatal ultrasound? Okay, and the answer to this is osteogenesis imperfecta. Okay, and those of you who like reading books, if you read this book, this answer would immediately come to your mind. This is a book completely about a girl who was born with osteogenesis imperfecta, and she was diagnosed antenatally by multiple fractures on the antenatal ultrasound. Okay, so this is how the ultrasound picture, multiple bone fractures will be seen. Okay. Okay, next question. A G2P1 presents at 28 weeks. On examination, the uterus is 24 weeks. On scan, there is absent liquor. What could be the most likely cause? Okay, the most likely cause is, could it be a renal anomaly, a heart disease, a tracheoesophageal fistula, or a hydrocephalus? The answer should be a fetal renal anomaly. So renal anomalies, we've discussed this, renal agenesis or dysplastic kidneys will lead to oligohydramnios, and this usually happens in the mid-trimester or early onset, and this leads to Potter's facies, which is pulmonary hypoplasia plus typical flat facial features. Okay, so that is fetal renal anomalies. Okay. So amniotic fluid and its abnormalities. This is normal amniotic fluid is this color. Okay, green is seen in meconium, right? This color is seen in golden yellow color of amniotic fluid is seen in golden color amniotic fluid is seen in RH isoimmunization, okay? Or basically when there is hyperbilirubinemia, okay? What is this? This is tobacco colored. Tobacco colored amniotic fluid is seen in intrauterine fetal demise, especially an old intrauterine death. And amniotic fluid, if red color or blood stained amniotic fluid is seen in abruption. Okay, so colors of amniotic fluid and what they represent is also an important part. Okay, let's continue. 34-year-old woman is advised an ultrasound and a double marker between 11 to 14 weeks. Doppler of the umbilical artery helps predict what? Doppler of the umbilical artery, does it help predict early onset preeclampsia or late onset? Remember, Doppler of the umbilical artery helps predict early onset preeclampsia. It is not a good predictor of late onset preeclampsia. Let us talk about preeclampsia screening, okay, because this is the new in thing. A lot of screening is done nowadays, and we do the screening between 11 to 14 weeks of pregnancy. 11 to 14 weeks पे और कौन सा screening हम करते हैं? Which other screening do we do? We also screen for Down syndrome. Okay, we also screen for Down syndrome, and we also screen for now preeclampsia screening. Okay. Now in this, what do we do in preeclampsia screening? We take the history. Okay. That is whether she has a previous history of preeclampsia or a history of chronic hypertension. Okay. And we do a uterine artery PI on the Doppler. Okay. So we do a ultrasound Doppler of the uterine artery and we take a pulsatility index. Okay. And we do biochemical markers. Which biochemical markers should you remember? Remember placental growth factor. Remember PAP-A and remember SFLT2. Okay. PLGF and PAP-A are reduced in women who are at risk of preeclampsia, and SFLT2 is increased. I'm telling you these because this is an expected question. Preeclampsia always is asked, and pathophysiology of preeclampsia is also a very important area. Okay. So based on the history, based on the uterine artery pulsatility index, and based on these biochemical markers, there are softwares available which calculate the preeclampsia risk. If she's low risk, nothing needs to be done. But if she's high risk, what should we do? We should start low dose aspirin before 16 weeks. Why before 16 weeks? Because this is when the trophoblastic invasion starts happening, the second wave. And we have to intervene before that so that the arteries are nicely dilated. Okay. So what do we give? We give 150 milligram of aspirin. It used to be 75 milligram. Remember, this is a new change. Okay. So we give 150 milligram. We actually give 2.5 milligram per kg body weight. And this works out to be mostly 150 milligram. Okay. So this is the dose of aspirin that is given now for prevention of preeclampsia. It used to be 75 milligram. Remember, aspirin is the only known method of prevention of preeclampsia, but it has to be given before 16 weeks of gestation. Okay. This is another question. The same paper, two questions came from etiology of preeclampsia. A 34-year-old woman develops preeclampsia. She is very anxious and asks why this has developed. You explain to her that there is a problem in development of fetal circulation. What is the cause for this? Okay, and the answer is poor invasion by villus trophoblasts of spiral arterioles, or villus trophoblasts of the radial arterioles, or extravillus trophoblasts of the arcuate arteries, or extravillus of the spiral arterioles. Remember, the arterioles affected are the spiral arterioles. And remember, the extravillus trophoblast is what is responsible. Okay, so remember two things. Extravillus trophoblast. Okay, these are the trophoblast which is responsible, and they invade the spiral arterioles and make them nicely vasodilated. So this is a nice vessel which is nicely opened up. But if these extravillous trophoblasts are deficient, the spiral arterioles remain constricted. So this is the main pathophysiology of preeclampsia, which you should all know. Okay, Primey at 12 weeks visits the OPD. She wants to know the additional daily calorie requirement she would need to take. Okay, what is the answer? The answer is throughout pregnancy, she requires about 350 kilocalories in pregnancy. That is what the ICMR says. Okay, but remember what, if you divide this trimester wise, in the first trimester, she actually requires no extra calories. This has come as a question earlier. In the second trimester, she requires around 350 or 340 is what's given in Williams, and 450 in the third trimester. On an average, this works out to be throughout pregnancy, 350 kilocalories. And in lactation, she requires an additional 500 kilocalories in lactation. Okay, so easy question. Okay, this is a question which has raised a bit of controversy. Last Neet PG question. On the second postnatal day, where will the fundus of the uterus be? Will it be 1 finger below the umbilicus? Will it be 2 fingers below the umbilicus? Anyone? This has a bit of controversy to it. Okay. So I searched and searched many books because honestly, it confused me also. It seems like a very straightforward question. But let me tell you what I found in most books. Okay, see, the confusion has started. A or B, A or B. Okay, so immediately after delivery, the uterus is, okay, at the upper border of the umbilicus. Okay, and this is immediately after delivery. Okay, and it's what Williams, not Williams, one of the other standard books, what it says is it stays here at, for 24 hours, it stays at that position. Okay, then from the first day onwards, it starts involuting. That means reducing in size by ½ inch, which is 1 finger. So on the first day, it's 1 finger below. On the second day, it is 2 finger below. Okay, so I would go with 2 finger below the umbilicus because most books give it this. But some books also say on the second day, it will be 1 finger below. I think one book says this. But I did a lot of research on this question. So I believe 2 finger below the umbilicus should be the more appropriate answer. Okay. Why? Because 24 hours it stays at the level of the umbilicus. And then on the first day, it's 1 finger below. Second day, 2 finger below. ½ inch every day. And it becomes a pelvic organ by 10 to 14 days. Again, some books say 10 days. Some books say 2 weeks. By experience, it takes this much time for it to become a pelvic organ. And it reaches the normal size after 6 weeks. That is after 42 days. Okay. Okay. 28-year-old woman on her third postnatal day, you go and visit her and you find that she is having occasional crying episodes, fatigue, and lack of sleep. So what is this? Is this puerperal blues? Is it depression? Is it insomnia? Is it anxiety? What is this? This is puerperal blues. Okay, so there are 3 things you should know in pregnancy: puerperal blues, postpartum depression, and postpartum psychosis. Psychosis is relatively easy to understand. Blues is very common. 80% of women will have blues. Okay, and it happens usually soon after. Why soon? Why is so? It's basically the mother is very overwhelmed. She's gone through labor. She's in pain herself, and she is very overwhelmed. She has a new baby to take care of, and I'm telling this out of experience. Okay, so it's a very overwhelming feeling for a woman. Okay, so you have a new thing to take care of, a new living being to take care of. Most women will end up crying, and they will feel very worked up. So mild insomnia, tearfulness. What's important to remember here is it occurs very soon after delivery, within the first few days. Okay, and it resolves by itself. All she requires is a lot of tender, loving care. Okay. Okay, somebody said second post day means first day after 24 hours. It means answer is 1 finger breath. Okay, so that's what this question is a little confusing. It's not framed very well. Okay, but I would still go with let's go back to this question because somebody asked second postnatal day. So day of delivery is day 0. This is what most of us say. Okay, and then first day, and then second day. Okay, so day of delivery would be day 0, and then you have the first postnatal day and the second postnatal day, is what I understand by this question. Many people may have a different understanding. So for 24 hours it remains there. Okay, and then on the first day it comes down by 1 finger, second day by 2 fingers. Okay, so this is, and this question is the exact question. Okay, it's not, there's no this is how exactly it was framed. Okay, so there's no doubts in that. Okay, but this would be a more appropriate answer. I know there's a lot of controversy in this. That's why I'm saying let's not spend too much time on controversial questions, is what I feel. Okay, let's do the questions which are not, I mean, don't waste time. So that's one rule I have. Controversial questions hamesha rahenge. 2-3 questions will be there in the entire paper. Don't waste time on them. They are not going to make or break your result. Your make or break is going to be by the remaining 98% questions. Okay. So, postpartum depression, remember, starts after 2 weeks. That's the major difference. Okay. And it continues for many, many months. Okay. And here she'll have more depressive symptoms and she may require pharmacotherapy or even antidepressants. Psychosis happens very soon after, and usually there's a very strong family history. Okay. So there is a strong family history of bipolar disease or psychosis in the past. Okay. Which hormone stimulates the male fetus to produce testosterone? This was a straightforward question. HCG, till the fetal pituitary takes over. HCG is what mimics the the fetal LH, and this is what produces testosterone in the male fetus. Okay. Okay, let's go to Rh negative mother. So Rh negative mother, which of the following is used for monitoring of the fetus in modern obstetrics? Is it biophysical profile, fetal blood sampling, amniospectrometry, or MCA? So remember, in Rh negative women, what do we do? Okay, somebody is asking which mother wants to harm the baby in psychosis. In psychosis, there will be feelings of infanticide, okay, not in depression, postpartum psychosis. Okay, MCA Doppler, PSV is what is done in Rh isoimmunized mothers. Okay, so we have Rh isoimmunized pregnancy, you have an Rh ICT positive. Okay, so this is another area which is important and it gets a bit confusing. So let's spend some time here. We have ICT positive mother. What does this mean? She is Rh negative. Okay, and when we do an indirect Coombs test, we find it is positive. What does this mean? This basically means she has antibodies to the D antigen. Okay, so she has antibodies to the D antigen. So if the fetus she is carrying is Rh positive, those antibodies will attack the fetal red cells and destroy them. So fetal red cells get destroyed. What does that lead to? It leads to fetal anemia. What will that lead to? It will lead to, so if the fetus is anemic, it will send blood to the most essential organs, and that is the brain. So the brain of the fetus is getting more blood flow if the fetus is anemic. Okay. So that is how we know as an obstetrician, if my patient is Rh negative with ICT positive, how do I know that this baby is getting anemic or this baby is getting affected? Okay, I know by doing a Doppler of the middle cerebral artery. Okay, so a Doppler of the middle cerebral artery where I look at the peak systolic velocity. If the peak systolic velocity are higher, more than 1.5 multiples of median, I know this baby is anemic. Okay, and if still nothing is done and the hemoglobin falls to less than 4 gram, fetal hydrops will develop and eventually the baby will die. Okay, so this is the principle of an Rh isoimmunized pregnancy. Okay, so what do we do? If your patient comes to us and she's Rh isoimmunized, that means ICT is positive, we call the lab and say, give us the titer. Okay, what will the titer tell us? The titer will tell us ki kitne antibodies hai, how many antibodies are there, are they small amount or are they large amount? If they're small amount, that means less than 1 in 16. That means 1 in 2, 1 in 4, 1 in 8, 1 in 16. I'm not that worried. Why? Because एंटीबॉडीज है बट दे आर लेस. ओके, सो इतने नहीं है कि वो फीटस को अटैक करेंगे. सो व्हाट डू आई डू? I repeat the ICT monthly till 24 weeks, then weekly. So if it remains less than 1 in 16, any of these three are there, I am not that worried. I just keep checking the ICT. But if the ICT crosses 1 in 16, that means 1 in 32, 1 in 64, 1 in 128, then I am worried, because now I know कि बहुत सारे antibodies है, they will attack the fetus and the baby will become anemic. Okay, so I need to check the anemia. And how am I checking? This is me doing an ultrasound, and that is the fetal head, that is the middle second. You see the nice circle of Willis, and that is the middle cerebral artery, which I am checking. This is telling me that whether this value which comes, the PSV which comes, whether it is less or more. If it is more than 1.5 multiples of median, I am worried that this baby is anemic. Okay. Now let's go back. Okay, let's go back. Mother is RH negative, father is RH positive. When she comes to me in the antenatal period, I do an ICT. ICT negative hai, to kya karungi? I am happy, but I have to prevent also this from happening. So what do? I give her anti-D at 28 weeks, and then I give her anti-D at delivery, within 72 hours of delivery, if the baby is RH positive. So इधर क्या चल रहा है? इधर चल रहा है prevention. Prevention of what? Of those antibodies actually being formed. So this is one question they can ask you. How do you prevent RH isoimmunization? How? By giving anti-D at 28 weeks and by giving anti-D after delivery within 72 hours of birth if the baby is RH positive. और इधर क्या चल रहा है? ICT is positive, but less than the critical titer. I know that I need to be a little careful that titers बढ़ने नहीं चाहिए. So if ICT remains less than 116, I deliver at 37 weeks. But if it goes to more than 1 in 16, then I do my PSV. And then what do? If it's more than 1.5 moms, and she's more than 34 weeks, I deliver. I don't wait anymore, because this baby is anemic. She's reached 34 weeks, I will deliver her. But if she's less than 34 weeks, what will I have to do? I will have to do a cordocentesis. That means, मैं ultrasound guided, I will put a needle in the umbilical vein, aspirate blood, check the level of hemoglobin, and if required, give that baby intrauterine blood transfusion. Okay. And if the PSV is less than 1.5, I know this baby is fine, not anemic, but can become anemic anytime. So I keep repeating weekly MCA Dopplers, and anytime it crosses this, I need to take action. If she's more than 34 weeks, deliver her. Otherwise, do a cordocentesis. Okay. Now let's go to, okay. Okay. So those were the obstetric MCQs, but I want to just take you through some images and some more important topics which can come in obstetrics. Okay, are you all with me? Should we continue? What is this? Because I'm not getting any messages on this thing since the last question. Okay. Let's start with these images. Okay, so the first image, what is the first image? These are types of twin pregnancy. Okay, on ultrasound. What is the first? The first is, what is this sign? This is the inverted T sign. Okay, and this inverted T sign is seen in which type of twin pregnancy? Anyone? This is seen in monochorionic diamniotic twins. Very good. And this is, okay, answers are back. This is lambda sign. Okay, lambda sign. Okay, or twin peak sign is seen in dichorionic diamniotic twin. This is a question which can come. It's one of the favorite type of questions in the exam. Okay, monochorionic diamniotic inverted T पतला सा line दिखेगा. अगर ये दिख रहा है twin peak sign, it is DCDA. Okay, if it is DCDA, deliver at 38 weeks. Okay, this is another one for your timeline. Okay, if it is uncomplicated MCDA, deliver between 34 to 37 weeks. And if it is MCMA, deliver between 32 to 34 weeks. Why? So MCMA, monochorionic, monoamniotic, you will also do directly a cesarean section. Twin में हमने क्या पढ़ा था? First twin non-cephalic, elective cesarean. Monochorionic, monoamniotic, also elective cesarean. Why? Why elective cesarean? Because of the risk of cord entanglement. The cords can get entangled. Okay, so elective cesarean is the rule. Okay, next. Next, what else? Yeah, so sorry. Correct. So elective cesarean, cord entanglement, and deliver them by 34 weeks is the rule. Okay. Okay. Now coming to delivery of twins. Okay. Now important to remember in delivery of twins is you have to withhold methergin. You have to clamp the cord. And this is very important. And note the time of the first delivery. Why is noting the time important? Because how much time do we have before delivery of the second twin? We have only 30 minutes. Okay. The second twin should be out within 30 minutes. So once the first twin is out, we clamp the cord. We don't give methergin. We check the time. Okay. And what do we do then? We check the lie and presentation of the second twin. If it is longitudinal lie, either cephalic or breech, we augment labor and deliver. But if it is transverse lie, here is the role for doing an external cephalic version. That means bring the head down or bring the breech down, external podalic version. And then what do? If this is successful, we deliver as cephalic or breech. But if this fails, we do what is called as an internal podalic version and a total breech extraction. Remember, I told you about breech extraction. Okay, so total breech extraction is done in the second of twin if an ECV or an external podalic version fail. Then we do an internal podalic version and a total breech extraction. Okay, so what are the indications for elective LSS in multiple pregnancy? First twin non-cephalic, monoamniotic twins, triplets and above, conjoined twins, and severe discordant twins. This means one twin small and one twin big. Okay, so your clinical question can come, how will you deliver? Like we had a question, first twin non-cephalic, monoamniotic twins, conjoined twins, triplets and above, and severe discordancy. That means severe difference in the weight. Yeah, PDF we will share. Okay, the PDF we will share, don't worry. Okay, so let's move on. Okay, another important area. Question, definite expect a question from in the last INI, at least several questions came just from one topic. It's also a question very commonly asked in FMG and Neet PG, and we will concentrate on what is antepartum hemorrhage, just the basic things, how questions come. What is placenta previa? What is abruptio placenta? Placenta previa, we all know, is a low-lying placenta. Okay. Now, what is important to understand is, number one, look at this image. An image can come. Can you see here? This is the cervix. Okay, and this is the placenta. The placenta is overlying the cervix. So this is a placenta previa. The best way to diagnose, or the investigation of choice, is a transabdominal ultrasound. A transabdominal scan is the investigation of choice in placenta previa. Okay, remember this. This is another picture showing placenta previa. Okay, this is the bladder. How do I know it's the bladder? Remember, anything black on ultrasound is fluid. It could be water, blood, amniotic fluid, urine. Anything black is fluid. So this is the bladder. This is the cervix. Nice cervix you can see here. This is amniotic fluid. And this is the placenta. Can you make out? So the placenta is covering the cervix. This is another picture of placenta previa. This is another one. Okay, I'm just showing you these images because these are expected images. This is the placenta. This again is the cervix. Okay, and the placenta is just coming to the lower part of the cervix. Okay, now placenta previa, if it comes in your exam, what is the typical clinical scenario that will be asked? It'll come as a 21, 20, whatever, 24-year-old primary gravida presents at 28 weeks with bleeding PV. She has no pain and she had a similar episode 3 or 4 weeks earlier. Okay, so remember, it is always painless. It is recurrent. So she'll have 2 or 3 or 4 episodes and it is apparently causeless. The classical history is she wakes up in a pool of blood. So there's no obvious cause. Everything has been going fine. Yes, PDF will be available. Those who are asking, everything will be going fine. Okay, but it's apparently causeless. So painless, recurrent, apparently causeless. As I said, investigation of choice is a trans-abdominal scan. However, a TVS can also be done. Remember, TVS is a trans-vaginal scan. It's in the vagina. We're not probing too much inside, but it can be done. But the investigation of choice is a trans-abdominal scan, not an MRI. MRI is useful only in some situations. Overall, if the question is asked, investigation of choice, trans-abdominal scan. What do you do in placenta previa? See the period of gestation. If she comes and she is more than 37 weeks, if your question says 24-year-old diagnosed placenta previa bleeding, she is 38 weeks, what will you do? You will deliver her. There is no waiting at all. Okay. A small break. We can take a break once obstetrics is done. In fact, I was thinking we can finish obstetrics and then do gynae later on. Obstetrics is almost over. So let's quickly finish it because we're in the flow and then we'll decide on whether to continue or take a break. Okay, so more than 37 weeks, immediate delivery is the rule and it is usually done by a cesarean section. Okay, in minor types, that is type 1 and type 2A, you can allow a vaginal delivery, but usually they end up bleeding. So cesarean section usually hota hai. Okay. Less than 37 weeks, what do? We look for 4 things. If the mother is fine, the fetus is fine. That means fetal heart rate good, maternal condition good, bleeding has stopped, there's no active bleeding, and there is no fetal abnormality. Okay? For example, there's no point if you have an anencephaly with placenta previa, there's no point waiting. You're just putting the mother at risk of bleeding. You know that baby won't survive. So there's no point continuing. So no or minimal bleeding, mother condition good, fetal condition good is when we wait. And this waiting is called as McAfee-Johnson management. Okay, so in McAfee-Johnson management, what do? We do what is called as expectant. We basically give her corticosteroids. We advise her bed rest. We give her hematinics, build up her hemoglobin, give her blood transfusion if required, and then deliver her at 37 weeks. But if एक चीज नहीं है, fetal distress है, bleeding रुक नहीं रही है, patient is in shock, then you will directly deliver her. ठीक है? But if you are fine, everything is fine, wait till 37 weeks and then deliver at 37 weeks. Okay, let's do some questions. 36-year-old lady with twin pregnancy conceived through IVF at 32 weeks with painless vaginal bleeding. This is the second such episode and ultrasound reveals placenta previa. Okay, so the diagnosis is given 32 weeks, twin pregnancy, placenta previa. Pulse is fine, BP is fine, fetal heart 1 is fine, fetal heart 2 is fine. So everything looks fine. Okay, what will you do? Will you do immediate cesarean or will you wait? In this patient, we will want to wait. So we will give expectant management would be what is done. We won't deliver at 34 weeks. We can take her till 37 weeks as long as everything remains fine. The best answer here is McAfee-Johnson's, which is expectant management. There is no reason to expedite delivery because she is just 32 weeks. Okay. Okay. Next. Okay. So they're saying, most of you are saying continue, no break. Okay. Even I don't want to break. Let's continue. Placental abruption. So placenta previa we've understood. Next is abruption. Remember, abruption is premature separation of the placenta. Placenta normally kab separate hota hai? Normally placenta separates in the which stage of labor? In the 3rd stage of labor. So if the placenta separates any time before that, it is called as abruption. So normally implanted placenta is separating. It is called abruption. Placenta previa, remember, there is a role for expectant management. That means where we know that bleeding is expected. Placenta नीचे है तो bleeding expected है, तो बहुत ज्यादा worry नहीं करना है. But in abruptio placenta, this is an obstetric emergency. Both are obstetric emergencies, but this is the real emergency. You will immediately deliver. Immediate delivery is the rule. Okay. Remember, immediate delivery is the rule in placental abruption. Okay. In placenta previa, we can wait. There is a role of expectant management. There is no role of expectant management in abruption. You have to deliver this patient. Okay. Now, classification is not that important. What is important is the diagnosis. Remember, diagnosis is entirely clinical. Ultrasound may help you rule out placenta previa, and it may show you a retroplacental clot. Can you see this? This is the placenta. This is the uterus. यहाँ से separate हो गया. Black क्यों है? Black because it's blood. Okay, but you may not see this picture. That's why diagnosis is clinical. Ultrasound will help you rule out placenta previa. Patient comes with bleeding, you're confused, what is it? Get a scan done, but clinical diagnosis is what is done for abruption. Okay, management, remember, immediate delivery is the rule. Okay, and so when to deliver? Immediately. How to deliver the patient? If there is distress, or if there is shock, you have to expedite. So the aim is to expedite delivery, whichever way you think is faster. If you think she's laboring well, contractions अच्छे आ रहे हैं, fetal distress nahi hai, mother is fine, okay, then give her a normal delivery. But if your clinical question says there is fetal distress, fetal heart is 100 beats per minute, or the mother is in shock, then you have to expedite delivery. Okay. If there is no fetal distress or IUD ho chuka hai, theek hai, then you can induce or augment. So it basically depends on how your clinical situation is asked. Okay, if you feel everything is fine, you can allow for a vaginal delivery. But if you feel there's distress or either fetal or maternal, then you have to expedite, and your question will give you the clue, like this one. 34-year-old primey at 32 weeks presents with bleeding. Her BP is high. So BP high hamesha socho will always go with abruption. Okay, 50% of abruption have high BP. It is an etiology of abruption. It's another clue telling you this is not placenta previa, this is abruption. Abdominal examination reveals the uterus to be 32 weeks. Also remember a tense, tender abdomen. So patient will have pain and abruption, and on examination, the uterus will be tense and tender. These are also clues towards abruption. Placenta previa mein uterus relaxed hoga, no tense, no tender, no pain, nothing. Okay. A vaginal exam is, so fetal heart is 100 beats per minute. Is that bradycardia? Yes, this is fetal bradycardia, and she is just 4 centimeters. So here you have a patient with abruption, with fetal distress. Okay. And she is 4 centimeters in labor. So what will you do? If you allow her to deliver, normally she will take at least 5 to 6 hours. Okay. So you have to expedite delivery because there is fetal distress with abruption. Even otherwise also, fetal bradycardia is an indication of fetal distress, is an indication for cesarean section. So APH का timeline क्या है? 37 weeks पे placenta previa हम deliver करेंगे, right? Or abruption? Immediate. So abruption doesn't come on this timeline. Abruption is immediate. Okay, so this timeline is very helpful for solving your clinical questions. Okay, so I want all of you to make this timeline. It will be very, very helpful. Okay. Down syndrome screening, I thought we will discuss a few things. Okay, so remember, because this also commonly comes as a question. Remember, Down syndrome is screening is done between 11 to 14 weeks primarily. Okay, so this is a recorded session. You can take a break and you can join in. I don't, okay, we'll take a 2-minute break if that's okay. Okay, then we'll start with Down syndrome screening because a few people are asking for a break. Is that okay? Okay, so we're taking just a 2-minute break. You guys can relax, stretch your legs. And how many are writing Neet PG in March? We can chat a bit. Okay, so my kids have slept. So I am here. I have nothing to do except take this class. Okay, some of you are writing Neet PG. Okay, continue. Okay, so let's continue. So Down syndrome screening, okay, is okay. Keshav is writing Neet PG. Okay, so most of you are writing very good. So let's continue this session and let's try to finish as much as possible. Okay, so Down syndrome screening. Okay, Down syndrome screening, remember, is done primarily between 11 to 14 weeks. So we have first trimester screening and we have second trimester screening. Okay, so we'll talk about both, but remember, primarily risk of Down syndrome is based on age. The elder the woman is, okay, the elder the woman is, the higher the risk of her having Down syndrome. Okay, so a woman at 25 years, the risk is 1 in 5,000. But at 45 years, this 1 in 20, it increases dramatically. Okay, so age तो है ही है. Age के ऊपर we have additional markers which help us tell to screen for Down syndrome. Okay, so when do we screen and how do we screen? We screen twice, 2 times we can screen. One is in the first trimester and one is in the second trimester. Okay, and how do we screen? There are 2 ways. We can either do biochemical testing or we can do an ultrasound or we can do both. Okay. Now, the first trimester screening, we do the ultrasound. Ultrasound pe hum kya dekhte? What do we see? We see the something called the nuchal translucency. What does this mean? The tissue at the back of the fetal neck. Okay, we measure that tissue. Okay, if it is more than 3 millimeter, it is a sign that this baby may have a chromosomal anomaly. Not only Down syndrome, it is a marker for other chromosomal anomalies also. And biochemical serum analytes, we do blood tests. We do what is called a dual or a double marker. Okay, a dual or a double marker is basically, the word itself suggests 2 markers होते हैं. इसमें एक बीटा HCG है और एक PAP A है. ठीक है. अब बीटा HCG कौन सा, which one is increased, which one is decreased in pregnancy is important to remember. Beta HCG is increased and PAP A is decreased in mothers who have Down syndrome fetuses. How do you remember this? Those of you who have attended my classes know how I teach this. B for big ya bada hua. So big B beta HCG is increased. PAP A is decreased. Double marker is beta HCG, PAP A, B for big, B for bada hua. So beta HCG high, PAP A low. Okay. And on ultrasound, we see the nuchal translucency. This is between 11 to 14 weeks. Very important. If your question comes, combined screening was done. So what do we do? What is combined? Combined is combining both. NT plus double marker is called as combined screening. This increases the sensitivity of the test. Okay. This image can come. What is this image? This is a fetus at 11 to 14 weeks. And this is the nuchal translucency. This is what is the NT. Very important image done between 11 to 14 weeks of gestation. Okay. In trisomy 21, beta HCG is increased, PAP A is reduced. Okay. In trisomy 18, what happens? Trisomy 18 is Edwards syndrome. Okay. Remember, both are reduced in Edward syndrome. So trisomy 18, Edward, both are reduced. In trisomy 21, beta HCG is increased, PAP A is reduced. How do you remember Edward? Remember Edward, King Edward of England. It was a man who abdicated his throne for the love of his life. Okay, so he gave up everything. He gave up royalty. He gave up his position as king. He gave up his throne to get married to the love of his wife. So he gave up everything. That's why everything is low. Okay, so that's how I remember Edward. Okay, trisomy 13 is Patau. Okay, in trisomy patau, papae is in, so wait, I might get this wrong. Okay, so let me just check this and get back to you, because I think I'm a bit I might have got this wrong, but Edward is definitely reduced. Downs we all know. Patau, I'll just get back to you. I don't want to tell you something wrong. Okay, now so remember, in first trimester this is what we do. We do NT, sorry, in first trimester this is what we're doing. In first trimester we are doing an NT. Okay, we're doing a dual marker, or we're doing a combined test. Combined test is NT plus dual, and this has the highest detection rate. Okay, now in the second trimester it is mainly the biochemical markers, and here we have two tests. We have a triple test and we have a quadruple test. Okay, triple test में क्या होता है? Triple test में होता है beta HCG plus alpha fetoprotein plus serum estriol. Okay, beta HCG, alpha fetoprotein, serum estriol. Quad में it's the same, beta HCG plus alpha fetoprotein plus serum estriol plus inhibin A. Okay, now which marker is reduced, which marker is increased in this? Wherever there is a B, those markers are increased. That means beta HCG is increased and inhibin A is increased. All the rest, alpha fetoprotein, unconjugated estriol, are reduced. That's how you remember dual, triple, and quadruple marker. Okay, so okay. Patau, it is decreased. Somebody has told me. Okay, fine. Good. Thank you. Okay, so this is what happens in trisomy 21 in biochemical markers. Beta HCG increased, the rest are reduced. Inhibin A is also increased. So whenever there's a B, that marker is increased. It is big, it is barawa. So that is an easy way to remember. Remember Edward's King Edward abdicated his throne, so everything is reduced. Okay, in Patau, okay, this is normal. Beta HCG, estriol is normal, and alpha fetoprotein is increased. Okay, these are not very important to remember, but Down syndrome you can't forget. Down syndrome has been asked in every single paper in the last 3 years. Okay, it is that important. Okay, so that's one area you can't go wrong. Now there's something called as NIPT. This also has come as a question. What is NIPT? So when you have a fetus in the mother's, whenever you have a pregnant woman, you have apoplastic, so you have trophoblastic cells which are undergoing apoptosis. Sorry. So you have trophoblastic cells which are undergoing apoptosis. They are dying, and their DNA, those apoptotic trophoblastic cell DNA, is entering the maternal circulation. So you can see this white DNA is from the fetus and the placenta, mainly the placenta. And that when we take a maternal blood sample, that those fetal or cell-free DNA is what is picked up, and it is subjected to genetic analysis and to Down syndrome screening. Okay, so this is what is NIPT or cell-free DNA. Remember, it is a screening test. It is not a diagnostic test. It is still a screening test because it is from apoptotic trophoblastic cells, not from fetal cells. So it is a screening test. It may pick up placental mosaicism. That is why, although it has a 99% detection rate, it still remains a screening test and not a diagnostic test. There are only 3 diagnostic tests. One is an amniocentesis, one is a chordocentesis, and one is a chorionic villus sampling. From here, we get fetal DNA. Okay, NIPT does not give us a diagnostic confirmation. This has come as a question. That's why I'm repeatedly saying it's only a screening test with a very, very high detection rate, but it is very expensive. That's why it is not still commonly done. To confirm Down syndrome, based on all these screening tests, we will give you a risk. The patient gets a risk scoring, and then we subject her to any of these 3 confirmatory tests. Okay. Okay, next question. So this is another controversial question. I don't think it's controversial, but many students might disagree. Let's see what your answer is. 3 abortions, the first at 8 weeks, the second at 11 weeks, and the third at 24 weeks with a history of early onset preeclampsia. Which of the following is the most likely cause of her abortions? Anyone? The confusion will be between these two. Okay, the answer will be APLA. Okay, this is APLA. This is not Kasowitz's law. Remember this. Why is it not Kasowitz's law? Because this is the clue they've given. There is early onset preeclampsia. Remember APLA syndrome. Okay, APLA syndrome is deficient trophoblastic function, deficient trophoblastic invasion. So APLA you will commonly find preeclampsia, early onset preeclampsia, abruption, intrauterine death. These are common, okay, and that is the clue they have given. Kasowitz agreed, the outcome looks like it is improving, 8, 11, 24. Okay, but this is not how syphilis will usually present. They won't be preeclampsia. Okay, so this is definitely APLA syndrome. This is not syphilis. What is APLA? APLA basically has clinical criteria. This is called a Sapporo's criteria to diagnose APLA. And you have laboratory criteria, at least one clinical plus one lab criteria should be there to diagnose APLA. And remember, more than the diagnosis, the treatment. How do you treat APLA? It is aspirin plus low molecular weight heparin is the treatment of choice. Okay, so aspirin plus low molecular weight heparin is how we treat APLA syndrome. Okay. Okay, so another motivation slide. Okay, so this is for this class also. Let's keep going and see where we reach. Okay. Okay, so some quick, and this is very quick. We'll do this quick images in obstetrics. What is this? I want quick answers. These are easy images. And expect one placental image. What is this? This is anyone? Okay, I'll give the answer. Okay, somebody's asking, is there any update regarding earlier sign? Earlier sign is still loss of DTR. There is no update. It is loss of DTR. Okay, this is a velamentous insertion. Okay, the cord is inserting into the membranes. This is a velamentous insertion of the cord. Okay, this is how velamentous looks like. What is this? This is battledore insertion. That means eccentric insertion. The cord is going in the side of the placenta. In the membranes, it is velamentous. This is battledore. This has no clinical significance. It's just an observation. Velamentous is seen. Okay, velamentous is associated with vasa previa. Remember V for V. Velamentous, vasa previa. Battledore is eccentric insertion. What is this when you see this white rim of tissue? This is called a circumvallate placenta. This has a poor pregnancy outcome. It is associated with abruption, intrauterine death, preterm. So bad obstetric history. Okay, what is this? This is a succensurate lobe. Okay, so these are very important. Okay. What is this? Okay, this I tweaked the question a bit. You've got twin pregnancy. I decided to put a triplet pregnancy. What is this? So you can see this is one placenta. So it is a monochorionic. So when you see one placenta or you don't see two fused placenta, this is monochorionic and diamniotic. Okay, don't get confused by three cords. This is monochorionic, diamniotic, two amniotic cavities, 1 and 2, okay, and a single placenta. Even though there are three cords, okay, these two triplets were sharing the same amniotic cavity. So this is monochorionic, diamniotic. Okay, again a clearer picture. Monochorionic, single chorion, two amniotic cavities. Okay, what is this? This is again monochorionic, diamniotic, but this is a twin placenta. The earlier one was triplet. This is the same thing, twin placenta. What is this? This is easy. You can see there are three separate placenta. So this is trichorionic, triamniotic. I'm just going one step ahead of the exam in anticipation that the examiners get tired of asking twins and they move on to triplets. Okay, so this is trichorionic, triamniotic. Okay. So it's easy to figure them out. They will give an easy question. They won't give something very difficult. Okay, what is this? This is again a question which comes almost every other exam. 36-year-old, 3 months pregnancy, and you see this picture. What is this? What is this? This is molar pregnancy. Okay. How do we know this is molar pregnancy? Seeing the snow storm appearance. Okay, so you have snowstorm appearance of typical of molar pregnancy. Okay, what is the best management option? What do we do in a molar pregnancy? We do a, whether it's complete or partial, we have to remove it. So we do a suction and evacuation. That is the rule. You have to do a suction evacuation. And then what do? You do post evacuation beta HCG surveillance. Okay, because what are we worried about? We're worried about choriocarcinoma. Okay, the incidence of choriocarcinoma is 15% with a complete mole, and it is 5% with a partial mole. So what do we do once evacuation is done? We do weekly beta HCG till the beta HCG becomes 0, and then we do monthly beta HCG for 6 months. Okay. So beta HCG surveillance is done weekly till 0 and then monthly for 6 months. Okay, this is basically because we are worried about choriocarcinoma, which happens more frequently in a complete mole. So the answer here is suction and evacuation. Okay, these are the 2 pictures which you can get here. 3 pictures actually. This is the snowstorm appearance on ultrasound. This is the typical grape-like vesicles which are evacuated out. And what is this? These are the bilateral theca lutein cysts, right? Which is again more commonly seen with complete mole. So whenever the beta HCG is high, you see theca lutein cyst. Theca means theca cell. Okay. And this is increased, the growth of the cell is increased with under the influence of beta HCG. So molar pregnancy, multiple pregnancy are where you see theca lutein cysts. Okay. Next question. Okay. Gravida 2, 13 weeks. This is the ultrasound. A large septate neck swelling was seen. What is the possible karyotypic abnormality? Anyone? Yes, PDF will be given. Don't worry. The PDF will be given. Those who are asking. Okay. What will you do here? What is this? Can you see the fetus? Can you see this neck swelling here, which is septated? If you look from this view, you see it is septated. What is this? This is a cystic hygroma, a large neck swelling, commonly found with 45XO, Turner syndrome. Okay, so this is a possible question. Turner syndrome is another favorite. It comes several times. This is a previous INI question, but it's an important question, so I put it here. This is an ultrasound image of a lady who said that her first pregnancy was an anomalous fetus and she underwent MTP. She is now anxious to plan her next pregnancy. What should be advised? What is this image of? This is a sagittal view of anencephaly. Okay, so sagittal view of anencephaly, which is an open neural tube defect. So what should you do? In the next pregnancy, when she comes, we have to start her on preconceptional folic acid 5 milligram per day for at least 3 months. Okay. This is, again, I'll repeat, anencephaly. Okay, you get 2 images of anencephaly. One is the frog face appearance. This is a sagittal view. This was asked in the exam. Okay, this view was asked. So you should know how anencephaly looks like on an ultrasound. Okay, next question. Again, commonly asked question. I've just framed it a bit different to make it an image-based question. But modified biophysical profile and biophysical profile is one question which you can't get wrong. You have to know this. Modified BPP is basically an NST plus an amniotic fluid index. Okay. So what is being shown here? Can you see this image? The black is being measured. The black, anything black is fluid. Amniotic fluid appears black. So this, and this 4 quadrants, we add up the quadrants. Normal AFI is between 5 to 25. Anything less than 5 is oligohydramnios. More than 25 is polyhydramnios. Okay, next question. What is this? Easy question. This is a CTG or a cardiotocograph. This is the cardio monitor, checking the fetal heart. And this is the tachograph, checking the uterine pressure. It's placed on the fundus. Okay, what is the difference between these two, CTG and NST? NST is done antepartum. Before the woman is in labor, we do NST, okay, non-stress test. And CTG is cardiotochogram. You're checking the uterine pressure also. So this is done during labor. The machine is the same. Everything is the same. It's just called different. CTG is the name given to it in labor. NST is the name given to it before labor. Okay. 25-year-old primary in labor at 5 centimeter and ARM is done, which shows meconium stained liquor. The CTG traces as shown. What are these decelerations? Okay, these decelerations are they early, late, prolonged, or variable? These are late decelerations. Why? Because can you see the contraction here? When the contraction is fading off, the deceleration is happening after the contraction. So after the contraction, so this is the contraction. If the fetal heart is dipping after the contraction, it is called a late deceleration. Late means chala gaya, nikal gaya. Late is a bad sign. That's why there is meconium also. Late means the fetus is distressed. So fetal distress. Okay, fetal distress is a bad sign. It's a late deceleration. Early deceleration कब होता है? Early होता है जब ये contraction है और deceleration ऐसे है. It is matching with the peak of contraction. And early is seen in second stage of labor. Why? Because the head gets compressed. Head gets compressed against the perineal floor, especially in second stage of labor. Head compression causes early deceleration. Okay, that's important. And variable means there is no relation. Okay, with the uterine contraction, there is no relation with the fetal deceleration. This happens in cord compression, which is seen in oligohydramnios. Okay, so remember these early, late, variable. This is always asked in the exam. Okay, these are questions which you can't afford to miss. Easy question. What is this? Is this what type of breech is this? This is an extended breech. Can you see the hip is also extended? The knee is also extended. This is also called a frank breech. Frank or extended breech. Okay. So this is complete breech or flexed breech, where there is flexion at the hip joint and flexion at the knee joint. This is a frank breech or extended breech where the knee joint is extended. And this is a footling breech. Okay, what is this image? This is a vulval hematoma. This looks like a hematoma which has happened post-delivery. Okay, vulval hematoma. Carcinoma will appear more ulcerative. Bartholin's will not be at this position. Bartholin's will be somewhere here. We have a picture in the gynae session on Bartholin's. We'll show you how it looks like. Okay, and sarcoma botryoides is again not a single lobule. It is multilobulated. Okay. Okay, forceps and vacuum. Again, two important images or clinical situations you can get. A 24-year-old primary is in labor at 39 weeks. During second stage, fetal distress is observed. All are prerequisites to applying this forceps. So this is an outlet forceps. The most common forceps you see being used and which will be asked in the exam is an outlet forceps. It is applied when the head is at +3. Remember, +3 means it is just there at the perineum. Anything below the ischial spine is plus. Anything above the ischial spine is minus. Below is plus, above minus. Okay, so it is down there. Okay, on the perineal floor, right there. Okay, so the fetal scalp is seen without separating the labia. Yes. Okay, the fetal skull has reached the pelvic floor. Yes. The head is on the perineum. Yes. But this is wrong. Okay, rotation should be within 45 degrees. That means internal rotation should have happened or should be happening if you are applying an outlet forceps. Okay, so outlet forceps can only be applied, remember, if rotation is complete or almost complete. That means less than 45 degree. If it is more than 45 degree, that means internal rotation, जो mechanism of labor में step है, वो नहीं हुआ है. We can't apply the forceps, the outlet forceps. Okay. Okay, so the rule is rotation should not exceed 45 degrees. And other than that, it is there on the pelvic floor. It is just there without separating the labia. You can see the head, the skull has reached the pelvic floor. Rotation does not exceed 45 degree and fetal head is on the perineum. Important point about vacuum. What is the correct answer to this question? The instrument shown below is placed at what point on the fetal scalp? Is it on the extension point, on the flexion point, on the anterior fontanelle or the posterior fontanelle? So remember vacuum. Okay, yes, you can apply if it reaches the perineum. Somebody is asking, you can apply once it's on the perineum, you can apply the forceps. Okay. Vacuum, remember, is always applied on something called the flexion point. It's easy to remember because flexion is what needs to be achieved. In mechanism of labor, the head gets flexed. Okay, so by applying a vacuum, you are aiding flexion. See this diagram here. Okay, this is the cup. Imagine if the cup was placed here and I pull, what will happen? It will extend. But the more posterior I place the cup on the head, okay, the more posterior I place and I pull, that will facilitate flexion. Okay. Now, so what is this flexion point? Flexion point, remember, is a point which is applied as posterior as possible. In proper definition, it is a point which is the diameter, the center of this vacuum cup should be 3 centimeters in front of the posterior fontanelle. Okay, so this is 3 centimeter. Posterior fontanelle is here. The cup should be applied here. This distance should be 3 centimeters. This is called the flexion point. In easy language, it should be, and in practical aspect, the question can come, where should you apply the cup? The cup should be applied as back as possible on the back of the head, because on applying the back of the head, when you pull, it will facilitate flexion. That is why it is called the flexion point. If I place it anteriorly near the anterior fontanelle and I pull, the head will get extended and it will never come out. Okay. Okay, easy question. What is the answer? This is diabetes. Okay, remember, overt diabetes or pre-gestational diabetes is associated with anomalies. And which is the most common anomaly? The most common anomaly in a diabetic lady is cardiovascular anomalies. In that, VSD is the most common. Okay, cardiovascular VSD is the most common. Okay, and this, what is this? This is called as caudal regression syndrome or mermaid baby. Okay, where you have only the limbs are fused, the bottom limbs are fused, sacral agenesis is there. This is called as mermaid baby. This is the characteristic anomaly. Remember, it's very rare, but if it is seen, always think of diabetes. It is the most characteristic anomaly associated with diabetes. But the most common anomaly is a cardiovascular anomaly. Remember that. Diabetes is the answer here. Also remember, GDM में anomalies नहीं होते हैं. And GDM does not have anomalies. Pre-gestational diabetes is the one which has anomalies. Okay. This we've done before, but this is the picture I was saying. What is this? What is this? Okay, right. This is thalidomide. Okay, what you're seeing here is phocomelia. Okay, characteristic representation of how teratogens work is the thalidomide tragedy which happened. Okay, and all these babies whose mothers received thalidomide, most of them had limb defects called as phocomelia. Okay, now quickly some new topics in obstetrics. What is Lakshya? Anyone knows what is Lakshya? I'll wait for the answer. What is Lakshya? It's come in UPSC, I think, UPSC exam. But what is Lakshya? So it's a potential question. Yes, famous history of thalidomide. Very good. The thalidomide tragedy of the 1960s. Okay, Lakshya, anybody? Okay, Lakshya is labor room. Yes, somebody's writing. Labor room quality improvement initiative. Okay, so it is basically a program started by the government of India. Okay, in the last, I think 4-5 years ho gaya isko, exact year I don't remember. But like NABH, we have for standardizing labs all over the country. Lakshya is to standardize labor rooms, especially in government hospitals and medical colleges all over the country, so that everything is very, very standardized. And again, respectful maternity care is given a lot of importance in this. Okay, to allow the mother to feel good. She should not have a bad experience in the labor room. So you should know what Lakshya is. Okay, this is Lakshya to reduce maternal and newborn mortality, to improve the quality of care. Okay, and RMC, they can get a question. What is RMC? Respectful maternity care. This, I'm repeating this again and again because it's very, very important. You go anywhere, everybody is talking about respectful maternity care. Labor care guide में भी आया है, Lakshya में भी है, respectful maternity care. What is this an image of? This is an ultrasound showing a rare kind of ectopic, which is now becoming very, very common. It's called a cesarean scarred pregnancy. It is an ectopic in the lower uterine segment, the area of a previous cesarean. So this is the uterus. Okay, you can see this is the endometrium. This is the cervix. And can you see in the myometrium here, the pregnancy is there. Okay, so this is a possible question in the exam. Cesarean scar pregnancy. This image can come. Other than that, there is no fixed treatment option. You can do a hysteroscopy, you can do a laparoscopy, you can give methotrexate. But remember, this is how a cesarean scar pregnancy looks like. More the number of cesareans, higher the risk. Okay. Placenta accreta syndrome is also possible potential question. What should you know? Remember, there is failure of separation. Why? Because the Nitabukes layer, I'm sure you've heard of this, is deficient. This is a layer in the decidua basalis. This is deficient. So what happens? The placenta can either adhere to the myometrium. This is called accreta, or it can invade the myometrium. This is called increta, or it can perforate, which is called as percreta. Okay, and go into the surrounding structure, most commonly the bladder. Kisme hota hai? What is the highest risk? The highest risk, remember, is this. Any woman who's had a previous cesarean and you do a scan and you find the placenta is low-lying, placenta previa, this always alarm bells should start ringing. Clinical question comes, patient comes, 30-year-old lady with previous 2 cesarean sections with bleeding. On a scan, you find that the placenta is low-lying. Okay, what is the next best step? The next best step should be to do the investigation of choice, which is an ultrasound Doppler. Okay, which will tell us whether accreta is there or not. Okay. Okay, so I'm just seeing some questions if anybody's asked. Okay, so investigation, you're right. Lakshya is a very difficult objective to reach. We had been trying in our medical college for the longest time, but it was very difficult. Okay, because there's a lot of barriers in the way, especially in a government institute. Okay, investigations of choice, ultrasound Doppler for placenta accreta. Remember this. Previous, this has come as a question in the past. Previous cesarean with placenta previa is the most common risk factor for placenta accreta. Okay. This is the investigation of choice. Okay. This is not important. This image is important. Can you see how vascular this structure is? So lot of vascularity is seen between the placenta and the myometrial interface. Okay, so this is how accreta will look like. Remember, this has come as a question. Investigation of choice is not MRI. Okay, MRI can be done, but the investigation of choice, the next best investigation, if it's asked, is a color Doppler. Okay, management. Okay, so this is a patient who we opened the abdomen. This was a patient who was not diagnosed to have a creta pre-operatively. Okay, she came in the emergency with a previous cesarean, and as soon as we opened the uterus, this is an actual picture of one of my patients. Okay, we opened the abdomen, and this is what we saw. Okay, so when you see this, you have to, this is something which is very scary. Okay, because if I had to give my lower segment incision, I would have given it here. If I gave it here, okay, this patient would have bled to death. Okay, so when you see this, okay, or if you've diagnosed a creta before, what should you do? Okay, you have two methods. You have to do a cesarean, so surgical has to be there. Non-conservative means you are removing the uterus. So the rule, practical approach is to do a hysterectomy. So if I see this is placenta accreta, what will I do? I will do a cesarean and I will then proceed to do a hysterectomy. Otherwise, there's no way you can separate this placenta. It's like a malignant tumor which was growing inside the myometrium. As soon as you try to separate it, it will bleed. Okay, so you have to remove the uterus. In some cases, you can, in focal accreta, if it's only some part adherent, you can excise that part and resuture it. Okay, but this is rare. Majority of cases, and for your exam, accreta means cesarean plus hysterectomy. And very important, which kind of cesarean. I can't do this. I can't give a lower segment. This patient will bleed. I have to not touch the placenta. So what will I do? I will give my incision here and take the baby out. This is a classical cesarean. So I will do a classical or an upper segment cesarean and take the baby out, okay, and then clamp the cord and then leave the placenta in situ and proceed with a hysterectomy. So remember, surgical non-conservative means a cesarean hysterectomy. This is how a cesarean hysterectomy specimen looks like. This is the placenta inside. This is the incision we gave on top and took the baby out. With the placenta in situ, remove the uterus. Okay, so remember, classical cesarean. Remember, when is it done? It is done between 34 to 36 weeks, because you don't want the patient to come to you in the middle of the night bleeding or in labor. So it has to be a very meticulously planned surgery, keeping everybody around you aware. So multidisciplinary approach, surgeon, urologist, blood bank, everybody is aware this patient will require multiple blood transfusions. So done before she goes into labor. And what do? You do a obstetric hysterectomy after taking the baby out. And don't handle the placenta. Don't touch placenta. Okay. So this is what is done. Okay, very important. Very, very important. Questions have started coming from here. MTP Act was amended with a very major amendment in 2021. इसमें पहले क्या था, अब क्या है? पहले क्या था? 20 weeks तक we could do an MTP. Okay, and उसमें भी ये था कि the opinion of one RMP till 12 weeks, and after 12 weeks, 2 RMPs have to give their opinion, otherwise you can't do an MTP. Now what has changed, very important, the upper limit has been extended till 24 weeks, but in select conditions. If you want to know the conditions, you can go and see my YouTube lecture, but I won't go into too much detail. Here, for your exam point of view, what you need to know, in select conditions, it's been increased to 24 weeks, but this is important. And this is very important because it's now coming in the news very often. Okay. There is no upper limit. Understand this. There is no upper limit in the new MTP amendment for substantial fetal congenital anomaly. Koi upper limit nahi hai. 24 weeks ka upper limit ho gaya for other things. Okay, but for fetal anomaly, substantial fetal anomaly, there is no upper limit. Patient comes with a complex heart disease at say 27 weeks. Okay, what do I do as an obstetrician? I ask them to approach the nearest medical college or the district hospital, and there a medical board exists. Okay, the medical board, this medical board. Okay, will sit and decide whether this baby, this anomaly is lethal, okay, or is it mild, or is it moderate, or is it substantial. If it determines it is substantial fetal anomaly, within 3 days it gives its decision that yes, you can go ahead with an MTP. Okay, so this medical board is there for more than 24 weeks. So now this has changed. Till 20 weeks, 1 RMP. Till 24 weeks, 2 RMP. And beyond 24 weeks, there is no RMP. The medical board, I can't decide. Patient comes to me. I recently had a patient. She had come at 30 weeks with Epstein's anomaly and fetal hydrops. They wanted termination. I can't decide. I have to send them to the medical board. Okay. And they will decide whether the baby requires termination or not. So this is very important. The changes are, number one, that upper limit has been increased to 24 weeks for select conditions, and there is no upper limit for substantial fetal anomaly. Okay, that is the major change in the 2021. Okay, so somebody is asking, classical is always a vertical incision. It is never transverse. We always go vertical if we're doing a classical cesarean. Okay. Okay, now this is the slide I was saying. These are topics you have to read if you're writing this NEET PG. Okay, go through all these because expect at least 2 to 3 questions from these topics. These are the obstetric emergencies: ectopic, eclampsia, APH plus Akrita, PPH, shoulder dystocia, cord prolapse, amniotic fluid embolism, and perimortem cesarean section. Perimortem, what you should know is if patient has cardiopulmonary arrest and she is more than 24 weeks, and after 4 minutes of CPR, she is not responding, consider doing a perimortem cesarean section. Okay. What is important to know, it is done where you are doing, you don't have to take the patient to the OT. It has to be done where you are doing resuscitation. CPR is continuing. You do a classical cesarean. This is another indication for a classical cesarean. Okay. And take the baby out. Okay. Why do you do this? You're not doing it to save the baby. You're doing it to reduce the gravid uterus pressure, which may be impairing resuscitation. Okay. That is why it is done. And cord prolapse, we've not discussed, but this has come as a question earlier. Cord prolapse is important because what you should know here again, the main aim is if the cord prolapses out, what happens? The cord gets compressed between the pelvis and the fetus, and that will lead to fetal distress and very quickly, very quickly, fetal death. So what is done? You have to do an immediate cesarean section, what is called a category 1 LSCS, where the baby comes out within 15 to 30 minutes. And while you are preparing, arranging for a cesarean, you have to relieve the pressure of the cord. How do you do that? By filling the bladder so that the full bladder will relieve the pressure. What else can you do? Put her in Trendelenburg's position, feet up position, or in a all-4 maneuver like we did for shoulder dystocia. Okay. Or you can push the presenting part away from the cord. Okay. But what you should not do is never ever touch the cord. If you touch the cord, vasospasm hoga. You're very tempted. Cord bahar aa raha hai, usko bahar andar dal do. No. Don't put the cord inside. Don't touch the cord. You are stimulating vasospasm, and that will hasten the fetal death. Okay. So this is what you should know. You should know all of these. Okay. Quickly go through. Most of them I've covered here. In fact, I've covered all of them here because they are very important. Okay. Okay. In perimortem mode of anesthetist, no, so not worried about anesthesia also. You are just cutting her open and taking, because you're not even catheterizing, you're not taking the OT, you are doing it then and there. Okay. You're not even worried about consent in a perimortem cesarean section. Okay. Okay. Okay, so let's start with gynae. Is that okay? Should we start with gynae or should we take it for the next session? Majority I will go with. I am ready. If you're ready, we'll start gynae. Anyone? Okay, nobody's saying anything, so let's start. Okay, gynae. 16-year-old girl with a partial transverse vaginal septum presents with dysmenorrhea and chronic pelvic pain. Which of the following is she likely to have? Okay, my YouTube handle is OBG classes by Dr. Raina. Okay, OBG classes by. So gynae will take another, I'll try to do it quickly, but 1.5 to 2 hours to lagega hi. Okay, I think we should finish it. I think that would be the best. Okay. Yeah, I'm feeling fine. I just have a bit of a cold. Okay, but let's finish it. Okay. A 16-year-old with partial transverse vaginal septum with dysmenorrhea and chronic pelvic pain. So this is the uterus, this is the vagina, and there is a vaginal septum. Okay, somewhere. It's a partial vaginal septum. So what do you think she will have? The answer here is she will have good. Okay. She will have endometriosis. Why? So any obstructive Mullerian anomaly. Remember, Mullerian anomaly is being asked like crazy in all your exams. They're asking every other exam. They're asking not 1, 2, 3 questions in every paper. Okay. In the last Neet PG or the one before that, I think 2021, 4 or 5 questions came from Mullerian anomalies. Okay. So any obstructive anomaly like a transverse septum, like an imperforate hymen, okay, will cause backflow of what? Of blood. So there will be hematocolpos. Okay, there will be hematometra. Okay, there will be hematosalpinx, and that blood will trickle down. So the theory of retrograde menstruation will happen, and endometriosis will happen in the pelvis. Okay, so that is, and endometriosis presents with how? Remember, endometriosis have 5 Ds. What are those 5 Ds? My health is fine, don't worry. What are 5 Ds of endometriosis? First is dysmenorrhea. Okay. Second is dull aching pain. Third is dysfertility or infertility, just to make it easy, 5 Ds. Fourth is dyspareunia, painful intercourse. And fifth is dyschezia, that means painful constipation. 5 Ds of endometriosis. Everybody should know this. Okay, if you see these symptoms and this has come in the exam, 5 Ds of endometriosis. Okay, so the answer here is endometriosis. Okay, so this we've discussed. Very easy question. These are all from 2021 Neet PG. Okay, 29-year-old was undergoing evaluation. This was done. What is this? This is very obviously a hysterosalpingography. The name of the investigation was asked. They can't be a simpler question. This is an X-ray. Dye has been injected. This is a unicornuate uterus. If you ask the diagnosis, you can see one uterus, one horn, and the fallopian tube. This is a hysterosalpingography. Next question. 28-year-old A3 with recurrent second trimester abortions was found to have a septa on a sonosalpingography. Okay, what is the best management option? So she has a uterine septa and she has recurrent pregnancy loss. What will you do for a uterine septa? This is a septa. What will you do? You will resect the septa. How will you resect the septa? By doing a hysteroscopic septal resection. I'll show you some images. I have them. Okay, let's go on. A 28-year-old woman was being evaluated for a uterine didelphys. Okay, this is again one of the controversial questions. Okay, this is a controversial question, but let's see. This is a didelphys. Okay, didelphys means complete separation of the Mullerian horns. They have never joined. So they're two separate, completely separate horns. Okay, now didelphys, remember, has a good reproductive outcome. It doesn't have many compared to others, septate, biconjugate. This has a relatively better reproductive performance, but it can cause increased incidence of abortions, and preterm labor are definitely documented. Preterm and abortions होते हैं didelphys में. ठीक है. Malpresentations are rare. Endometriosis also is rare. Endometriosis tab hota hai when there's something called as O-Vera syndrome. This is a known syndrome where there is obstructed hemivagina. Okay, OHV is obstructed hemivagina, and IRA is ipsilateral renal agenesis in a woman with a didelphys uterus. So O-Vera syndrome is, so when there's obstruction, half the vagina is obstructed, so endometriosis is seen. Okay, so O Vera syndrome, which is associated with didelphys, में endometriosis होता है. So इसलिए I think the correct answer here should be a transverse lie. Malpresentations are very, very rare with a uterine didelphys. Okay. Okay, this came in last Neet PG, and there's a lot of controversy again related to this, but I made this very simple. What is this? Is this septate or bicornuate? This is a septate uterus. How do we know? Because this intercornual angle is less than 75 degrees. So if it's an acute angle, okay, it is septate. If the angle is more than 105 degree, it is a bicornuate uterus. Okay, I think most of you are very familiar now with these HSG pictures, how to differentiate. Okay, so when we talk about Mullerian anomalies, I won't go into the classification, but let's talk about the different anomalies which you should know. One is MRKH syndrome, which is called as Mullerian agenesis. Okay, how will this present? This is complete, nothing is formed. Okay, so no uterus, no cervix. Okay, so uterus, cervix, fallopian tube, and upper 2/3 of vagina are absent. They are not there. So how will this patient present? She will present with, okay, so somebody said inconclusive. Agreed. HSG is not a good investigation of choice for bicornuate septate. Okay, but that option is not there. So we have to go with something. Okay, or that option was there. But still the better answer is a septate uterus. Okay, so septate uterus would be the correct answer there. Okay, presentation here is primary amenorrhea. Okay, is the presentation of Mullerian agenesis. Okay, renal and skeletal abnormalities commonly are seen with most Mullerian anomalies. How do you diagnose this? How do you diagnose MRKH syndrome? There will be an absent uterus. Okay, so on examination, on doing an ultrasound, you will find an absent uterus. What do you do? How can you treat her? You can't get her a uterus, or can we? Is there any way we can get her a uterus? Anybody? How can we get her a uterus? Newest advance in obstetrics, one of the newest advances in gynae. We can get her a uterus. How? By offering her a uterine transplant. Okay, so this is the new thing in gynecology. Only one transplant has been done in India in 2018 in Pune, and that lady had a IVF, successful, delivered a baby 1 year later. Okay, so transplant is an option now. Okay, rarely done. I think less than 100 have been done the world over. Okay, and one in India. Okay, but the main thing is to give her sexual function. Okay, and for sexual function, you have to give her a vagina. So we do a vaginoplasty. That is, we create a vagina. Okay, so yes, uterine transplant is a thing. Okay, and it is a very, very recent thing. And remember, when we transplant the uterus, the only way she can conceive is by IVF. Okay, and IVF was done for that lady. She had a baby girl and she is fine. Okay, so that is what is important. Okay, these images quickly. What is this? This also came as a question. This is a unicornuate uterus. Okay, remember, unicornuate uterus can have a rudimentary horn. Okay, and if it has a rudimentary horn, again can present with endometriosis or an ectopic pregnancy in the horn. Okay, that's also important to remember. This is the image I was saying we have on septate uterus. Okay, Dr. Sir is saying, please consider taking a break. Okay, so what does everybody say? I am ready to do this session, or I think we take a break and we can do gynae in a separate session, if that's okay with everybody. I think that would be better. Okay, we'll answer your doubts, but I think we'll stop. Sir has also said this. Let's take a break and we can do another session in the coming week. Okay, everybody's saying the separate session done. We'll do a separate session, but thank you everybody for attending this session. Yeah, we'll do a separate session of gynae. I think that's a better idea. It's already 12. I didn't even see the time. It's almost 12. Okay. So somebody is asking, is the transplanted uterus removed after the family is complete? Yes, after the family is complete, after IVF is done, the uterus is removed at the time of the cesarean section. The uterus is also removed. Okay. Okay. Vaginoplasty is the treatment. Yes. Okay. Okay. Done. I'm taking a break. We'll end the session. Thank you, everybody for attending. We'll inform you very soon for the gynae part. Okay, gynae is actually less, obstetrics was more, but we'll do it in another session. Thank you, everyone. Good night.